Okay. Good morning, everyone. Stephanie and I are back. You're going to be my star for all my recordings, Stephanie.
Yay.
Not exactly what you had expected, is it?
No,
Um,
it's okay.
this is the Oasis E1, brand new for this January. It is January 2025. We're all bundled up this morning. That's also very unusual for Florida. People are going to be wondering, why are they so bundled up? This is the night that we had all hoped that we were going to get snow. If we were a little bit further north, we would have gotten snow. We just got a bunch of rain and it's really, really cold, right? So, but no snow for us here in Gainesville, but they did get it in Tallahassee. So that kind of gives you a timeline of when we're recording this. So we are going to do the Oasis E1, and I'm going to share my screen with you, and we are going to jump in. So this is a brand new Oasis. Can you see my screen, Stephanie?
Yes, ma'am.
Okay, so this is not hugely different from the Oasis that we just had. Um, let's see if I can move us so I can actually see and move things around like I need to. Let's see if I can move us so I can move. I never know where to put our pictures. Let's see. Let's see if I can move us here. There we go. I'm going to put us over here today. Okie dokie. Let's try this over here. Okay. So I'm not going to go over every single item with you because that would be very, very long. So if you recall when we went through the start of care, the Oasis E1 fits right into the start of care in crescendo. Those are the items that are in red, and now we're going to go through those items in a little bit more detail. We're going to go through just the items that are most related to reimbursement, and the items that people tend to make the most amount of mistakes on. So we're going to just kind of go through these. These are the questions that I've given you that are just the questions. And I used to give everybody the entire manual, and it's very, very thick. It's about this thick, but most of it is accessible. There's a little eye icon. When you're in answering the Oasis questions in Crescendo. So you have access to a lot of this information when you're actually answering the questions when you're doing a start of care or you're doing a rock, which is a what again? What does the rock stand for, Stephanie?
Resumption of care.
When you're doing a resumption of care or you're doing a recert, which is what?
Um, uh,
It's okay.
forgotten.
What is the recert?
Res I can't think of it.
Sure, you can't. You know it.
Um,
Recertification, recert. So the
res
the certification,
oh, when it's you mean at the end of your 60 days.
yes, at the end of your 60 days. And remember, everybody that I'm doing this with is new to home care. So they're thinking the same thing that you're thinking, okay? So
Okay,
I don't
good.
mean to be putting you on the spot, but nobody that's going to be watching this has probably familiar with it either. So if they've done the Oasis, some people might do, but they probably are not familiar with these questions either. So don't feel uncomfortable that you don't know them. And some of them are probably sitting there thinking, boy, I'm glad she's not asking me these questions. So don't feel uncomfortable about it because I want
Okay.
to use Teach Back with you because I don't want to slight you. I want to be sure that you're getting this reviewed with you just like I would be reviewing it with them. Okay?
Okay.
So, so we're going to start. So a lot of this information, when you go to do an OASIS assessment, a lot of this information will already be populated in through intake. Okay. So you're
Mm-hmm.
not necessarily going to be putting in every one of these items. Okay.
Okay.
And let me get in the right place because I'm not even in the right place here. So let me get my book set so I'm in the same place here as you are. So what I'm trying to do here is I've tried to put um, in purple some of the input that I'm giving you in instructions, and it jumps around a little bit. I apologize. Remember, these are your books, so if you want to write any additional information or anything, feel free to do that. Be sure that you have something to write with or to highlight, however you want to do that. So all of this information should be in there to start with. Um, Okay. So, and I'm not saying this intending to be political. We just had an election. What, the new president was just sworn in on Monday. Today is Wednesday. So what CMS was saying with this question, with the way to answer it, and I'm just trying to give you information on how to answer the question. CMS is a government entity. The last time when they gave this question, we have the choices of male and female, um, and they gave us the additional information that at this point, CMS was just giving those two choices. But if a person did not identify as male or female, we were to put on there what they identified as. We could use either um, observation, or we could put on there what they said, but recognizing that if they identified with something different from their birth gender, that CMS might reject the claim. And my teaching was that I think that we should inform them of that. Oh, and I forgot to say at the very beginning, so let's talk a little bit about the Oasis as a tool, first of all. And then we'll go back to this example. So I'm going to assume that most of you are not familiar with the Oasis and what it's used for and who it's used for. So for those of you who have been in Florida for a long time, Stephanie, have you been in Florida for a long time?
Yes, ma'am.
Okay. Did you ever do the FCAT yourself or have any of your kids do the FCAT?
Yes.
So this is basically the federal government's equivalent to the FCAT, but for home care. That's
Okay.
the best analogy I can give you. Um, we know that for the FCAT, it was a state test designed by the state of Florida to measure outcomes for schools. It drove our curriculum. It drove what the teachers taught the kids. And based on that, it drove their merit pay. It drove their rating, how they were given a grade, correct? The scores were all given a grade. Um, that's very similar to what's going on with uh, the Oasis. It's a federal thing from CMS. Um, it's how we are rated. Now it's become it's as part of value-based purchasing and patient-driven grouping model. It's now become how we are rated with other national home care agencies. It's now a national program. We're given stars instead of grades. Um, very much how we're paid, how we're rated. Um, the powers that be from CMS came up with a lot of these questions, how we're to answer them. CMS has determined what they expect our patients to make. And this and a few of the other outcomes that we talked about on the patient satisfaction when we did the policies and procedures, that's a third of our rating on those policies and on the policies and procedures. When we talked about the policies and procedures, we talked about the patient-driven grouping models that were paid from three different things. We're paid based on the patient satisfaction. We're paid based on the Oasis, and we're paid based on a few outcome measures that are just claims data that's reported, right? You remember that?
Yes.
This is the test part that's very, very similar to the outcome measures that we had from the FCAT. But that was done based on for our kids in the schools, but this is very, very similar for home care. And this is the test just for home care. And a lot of the changes they've made are things like they want us to include more standardized measures. Um, they're trying to do it so we're all using the same language across the whole continuum of care, from the acute care setting to home care to outpatient to the skilled nursing facilities. So that's kind of how the Oasis, that's kind of in a nutshell what the Oasis is all about. Um, they tweak it about every year. They kind of go in and make usually sometimes dramatic changes as they did a couple years ago. In this case, from the Oasis E to the Oasis E1, they made really pretty minor changes. They left out two pretty insignificant questions, and they added one question in tracking um, COVID vaccines. So we now have to track COVID vaccines. Um, I put in here why they added in different questions. Um, and the reason I'm going to talk about this question, it's right here for you. The key's right here for you, is that because some of this is politically driven, and so it's kind of changed the explanation for this one question. So that was the whole reason why I mentioned that at the very beginning, because this now might change just because of politics, actually. So all of this is for CMS. We do the test with everybody 18 years of age or older, with the exception of certain GYN conditions. And that's who we give it with. It's a Medicare and a Medicaid product. But um, my understanding is very soon, because it's a really good database. Um, it's a good thing for measuring outcomes that a lot of other um, insurance providers, even though it is a Medicare product, a lot of other insurance providers are probably going to start adopting the use of the Oasis just because it's a way for them to collect data on our patients. They're trying to ensure more accountability for home health agencies. As we look at some of these questions, to be honest, we really don't have a whole lot of control over. Just like the FCAT, some of the things that we were measured on, we honestly didn't have a whole lot of control over. Um, During the height of the FCAT, actually was I was consulting in a pediatric setting. I had a private practice and I was consulting, and I was working in a school, and I was working in a high school setting. And I was responsible. I had three groups of high school kids, and this is a very relevant story I'm telling you, because I had classrooms of kids who could not pass the FCAT. And if you remember back to 10th grade, what happened if you had a 10th grader who couldn't pass the reading FCAT? Do you remember, Stephanie, what happened?
Um, no, that's a long time
They
ago.
they were not given a regular high school diploma. They were given a certificate of completion. It,
Oh,
it was
I
very
didn't
high
know that.
stakes. If they couldn't pass the reading FCAT, they were given a few other opportunities to retake it in 10th grade, 11th grade. But basically, and most of them just would drop out. A lot of them would drop out. But if they couldn't pass that 10th grade reading FCAT, they could not receive a regular high school diploma. They were given a certificate of completion.
Oh,
So I had a 10th grader come in to me the night before the reading FCAT. And I had worked very, very hard because I was their intensive reading, because I can teach anybody how to read. I'm a speech pathologist, but I can teach anybody how to read. And she came in, she said, Miss Hoffman, guess where I'm going tonight? And I said, I hope to bed early. And she said, no, it's my brother's birthday and we're all going to Busch Gardens. I said, your FCAT is tomorrow. She said, "Yeah, I know." And what do you think was running through my mind? I'm going, we have worked so hard. And, they talk about in statistics that error. And could I do anything about that? As hard as I had worked with her all semester on helping her with being able to pass this test. And the night before the test, her parents were taking she and her siblings to Busch Gardens. They had some kind of late night thing to go ride roller coasters to celebrate her brother's birthday. Okay. Want you to remember that story because there's a lot of stuff when we're going through this Oasis. You're going to look at that and you're going to think, how can we control that? And you're exactly right. We don't have a whole lot of control of that any more than I had control over this kid who wasn't going to get a regular high school diploma. If she didn't get a good night's sleep, it was going to probably impact how well she did on the FCAT the next day, and there wasn't a whole lot I could do about that. So that's kind of the Oasis. Okay, so let's go back up to this question. So the last 3 years, 4 years, what CMS has been saying about this question is for right now, and what I was saying is my guess is that in the next um, revision of this test, there were going to be more choices for this. Just like in a lot of our forms that we're using for medical forms, there are more choices than just male and female, right? They're giving you more choices than that. Because from a medical standpoint, in some cases, it's going to make a difference regarding the care that we give and what we do with somebody. Um, and so what CMS was saying in the last version of this that came out was for us to, the only guidance it was giving us was that it was going to give us more guidance moving forward, but that all they could say right now was that base the information based on what the patient said, and maybe tell them that they're if they identified with something that was contrary to their birth gender, that it may not be covered. Now, I told you that this is done for everything but certain GYN conditions, and the only example I could ever think for that was, for example, if a person came in and they identified as male and they had ovarian cysts and something had happened that they had burst and they had had some kind of a problem that had driven them to be hospitalized, then I felt like we should probably tell them that it may not be covered. Well, now this past week, and I don't know what implications that's going to have, but the new president is saying now he made a statement about now there's only going to be male and female. So I don't know what the impact that it's going to have. And again, I'm not making this as a political statement as well, but we are in healthcare. So that's part of why we need to be aware of these things do have an impact on, in some cases, the whether this is going to stay this way, whether CMS is going to continue to give us different directions on how they want this question to be answered by us. Every quarter, they send out updates on how they want us to interpret these questions or how they want us to answer these questions. It's their test, so they can do whatever they want. And sometimes they take a question, they don't revise the question, but they completely want us to interpret it differently. So I will let you all know what happens if they decide to interpret this differently. Um, I just know that this week, this has been interpreted differently from our government standpoint and from a health provider standpoint. How that's going to impact us, I don't know. And again, it may sound like I'm talking politics. I'm really not. But what I always tell my girls is we need to be aware, and a couple of my kids are in healthcare, because it does impact us as providers and how we're supposed to approach what we do and what we say and how we look at these questions and the questions that we ask. Was I clear on that, Stephanie? I
Yes.
kind of feel like I talked in circles a little bit. I'm trying
No,
to
that was clear. It was good.
good. I'm trying to be very It's just kind of really matter of fact, honestly.
Yeah.
So, speaking of one thing that is very much on CMS's radar is this whole issue of culture and health disparities and access to care. They did um, establish a whole division on ethnicity and access to care. Um, and so, this question, any of the questions, so the old questions start with a letter M, and that stands for Medicare. When this version, not the Oasis E1, but the Oasis E came out, which was in 2 years ago, it was the largest revision of the Oasis in, gosh, I think the Oasis came out in 1989. It was the largest change we had had in, gosh, 20 years. And part of it was in response to CMS's commitment to make sure that all of their clients had equal access to care and to address this whole area of social determinants of health. So let's talk about that for a minute. So I'm going to have to put you on the spot again. And unfortunately, Stephanie, it's just you. So again, don't feel uncomfortable about this. So what do you know about social determinants of health? And I can tell you that I've seen the whole range from people who come in and say, I've heard it before, I have no idea really what it is, to people who are pretty well versed in social determinants of health. What has been your experience thus far in social determinants of health? What do you know about it?
Well, my first thought is that it means like maybe like your maybe how to say this? Like your status in the community, like on how much money you have, maybe where you live,
Hmm.
um, like your environment.
Yep. Yep. You're exactly right. Yep. That's
Okay.
all part of it. Social determinants of health. So we know what the determinants of health, things that determine your health. The social determinants of health are just the things that you mentioned. That's some of them. The other determinants that are really more social factors that determine what your health outcomes are going to be. So you exactly nailed some of them. So things like one of the examples that I heard is and implications for us. So a nurse is going out, she has a diabetic patient. She's talking to that diabetic patient about the foods they're eating, and yet this person has food insecurity. They have no money to buy good food. And we know that people with low income, they tend to buy what kinds of food? Do they tend to buy fresh fruits and vegetables and things like that? Stephanie, do they
Who's
tend
that?
do people that have of low income, do they tend to buy a lot of fresh fruits and vegetables and things like that?
Oh, well, I guess not.
No, what types of foods do they tend to buy?
Maybe in a can because
Canned
they're
and
cheaper. They
mhm,
can last longer.
sure. What else do they tend to buy?
Um, like processed foods, like in a bag
Yes.
that could stick around on the shelf.
Yes. Think back to when we were in college. What do we live on? Ramen noodles, macaroni and cheese,
Yeah.
things like that. Exactly, that's exactly right. They're less expensive and you can stretch them. Canned soups, lots of processed foods that are inexpensive that you can stretch and fill you up.
Yep.
And so, one of the big things that we hear coming out of CMS is, here, nurses need to be aware that, I mean, because I'm talking to a nurse, so I'm not picking on nurses, but because you're a nurse, nurses need to be aware if they're working with a diabetic patient, if this person has food insecurity, they may not have the resources to stay on a diabetic diet if they don't know that they don't have the money to buy it. So we need to be thinking outside the box a little bit. We need to be working collaboratively and interprofessionally with our team members because we ourselves may not have all the resources. We might know what we need to tell them about eating healthy, but we maybe need to bring in the social worker to get some community resources in to help them to be able to have them the resources to be able to get the food to do that.
Yeah.
Maybe they have um, job insecurity, that they're not sure. Gosh, you work in some of our rural areas, which we serve a very wide area. You go out to Old Town and they talk to you about there's no jobs for my kids. When they finally built the grocery store out there, everybody was so excited that maybe there would be jobs for their kids because there's no employment out there. There was nothing out there. There was a grocery store. Um, I mean, there was a little fast food. There was no grocery store. There was a uh, gas station. There was a Subway. Every place has a Subway. But they were so thrilled to be getting a grocery store out there because there's just no jobs. Their kids, their youth have no jobs. They put in in fact, they didn't even have the Subway to start with. When I first started going out there, there was not even a Subway out there. Um, the physical therapist might be saying to go outside and walk, and their neighborhood's not safe to go out and walk. So
Yeah.
we need to be aware of these things. Transportation, they miss visits. They don't pick up their medications because they've got no reliable transportation or they've got no transportation. Okay. So we
Yeah.
need to be aware of these things, their education, their health literacy. All of those things that you mentioned, their educational level. And we have a lot of patients who they present themselves pretty well, but they might not have more than a fourth grade education because they had to help the family. So they had to drop out of school because they had to work. So we need to be aware, and all of those things go into their social determinants of health. Okay. So CMS added in a lot of questions to help to look at some of those things because they want to start taking data on some of that to be sure. And I always talk about with us being in home care, we are the front line in helping with some of those health disparities. And some of those patients and access to care, we should be very proud of what we do. Some of those patients that we think, oh, they're 45 minutes out to see that one patient. Yes, but if we didn't drive out to see that one patient, chances are they wouldn't be getting any care. So we should be very proud of the fact that we are providing care to those outliers that otherwise wouldn't be getting possibly any care at all. So that's the ethnicity question. They added this to look at culture. They
Okay.
added it in to collect and track quality of care and health outcomes. And the point is that you might need to add a cultural item to your care plan if you find that there's an issue with this. So if the patient is unable to respond, a proxy may report. However, if the patient declines to answer, don't enter the proxy's report mark as declined. So for most of these questions, if the patient is not able to respond, then you're going to mark the patient declines or the patient is unable to respond. And in most cases, if they're unable to respond, um, or they decline, then you're not going to be marking what the caregiver says. If they give you these choices, and that's what you're going to pick.
Okay.
Okay. And notice in here, check all that apply. Okay. Now I want you to notice something else. And I want to point this out to you. And it takes a few extra minutes to pay attention to some of this stuff. But I want you guys to know that none of the questions that are added to this are just willy-nilly. CMS has a reason for adding all of these questions. Stephanie, when you look at ethnicity, what do you notice about this group that CMS has added in?
Um, there's there's a lot of them.
There are.
Um,
What else do you notice they have in common?
let's see. In common, I don't know.
Do you see anything missing from this group, from this list?
Is it the Latin? They don't have that one in here. I don't know.
Well, they don't. What else don't they have in there?
White, black. Indian, Chinese, Filipino. I don't
They
know.
don't have a whole bunch. Again, we're not being racist and having these conversations. We're just noticing. Okay. And I find this very interesting that when they are looking at, again, they're doing this to look at certain cultures. Well, this is very interesting. So this version came out in 2022, I believe. I find it very interesting. Look at the specific cultures that they're looking at. They're not looking at a wide variety of cultures. They're only tracking information on Hispanics, Latinos, or Spanish origins. Any ideas why you think that might be? And those
Maybe because that is um like a large portion of their patients.
are they a large portion of our population?
I don't know.
You don't know?
No.
And those of you who are watching this, I want you to be asking yourself the same questions. I don't want you to just sit here listening, watch Stephanie struggle and think, boy, am I sure glad she's not asking me those questions. I want you to, so I think we should be asking ourselves these questions. I think we kind of have, I encourage you to be a critical thinker when you're doing these things and not just going in and answering these questions without wondering, gosh, they're asking me these questions on culture, but I wonder why they're only interested in Hispanics, Latino, and Spanish.
I have wondered that many times.
Yeah, I wonder why that is. So I can only, and again, I think it's always important to look at the context of when this version of this test came out. Um, I mean, I'm only taking a guess because they don't tell us why that is. So this came out in 2022. So, anytime when everything is reported to the Department of Health, when communicable diseases and things come out, everything has to be reported to the local departments of health, right?
Mm-hmm.
That's how we know the statistics on flu and COVID and all that stuff. Everything is reported. So that's how we know the different numbers and whatnot.
Mm-hmm.
Do you know the groups that did the worst, that fared the worst with COVID?
Oh, I didn't know that.
Do you know which groups fared the worst? That there were inequities? See, we're talking about equity. We're talking about access to care and equity. What do we know about COVID now? We know we have a lot of data on COVID. What do we know about COVID now?
Well, that maybe that the vaccines, people were still getting sick even though they got the vaccine.
We know that. Yeah, we know that. What else do we know?
Um, there's some medicines on how to treat it.
Yeah. What do we know about we're talking though about groups of people. What do we know about the groups of people? We're
I
talking
don't
about we're,
know.
we're talking about just data. I mean,
Data.
what you said is true. Some people did get sick. When the health departments collected all of that data, see, this became such a political thing. Again, it's like we're talking politics, but we're really not talking politics because there is, and it's going to sound like we're talking politics, but we're really not talking politics because we all got majors that were in science, right? I mean, you're a nurse, so you had to take a bunch of science courses. I had to take a bunch of science courses. I had to take neurology and biology and all these classes. So the information that we have and the reason they're asking these questions, people check boxes and then they put them all into this big database and they spit them all out. Do we know which groups fared the best?
I don't know, but maybe they figured that out from the data.
Yeah. So see, I'm curious. I'm always curious and I go in and read these things. In fact, so I just found out some more information that I will share with you, which I find very interesting because I'm the doubting Thomas. I don't ever believe what somebody just tells me. I've been this way all my life. I probably drove my mother crazy. If somebody tells me I don't just take their word for it. I go in and I have to dig myself. And I'm the one who says, prove it to me. And I'm going to go in and I'm going to dig and I'm not going to take just one source. I'm going to go in and I have to find two or three different sources. So, what we now know from COVID is that the people who fared the best are people who look like you and me, men and women who looked like you and me, who were white skinned and who looked like you and me. We know we have a fair amount of data on African American people. We don't have quite as much data on Hispanic, Latino, and Spanish. But we know from COVID that people who were dark-skinned African American and Hispanic, Latino, and Spanish did not fare as well. And they had more deaths per people who came in. They had a higher death rate than people who were, I call myself a European mutt because I'm really a European mutt. I have a lot of different, I have Swedish in me, I have German, I have all kinds of different things in me. But they did not fare as well as what people who look, which is really the race part, but now we're talking the ethnicity part. So ethnicity wise, people who were of Hispanic, Latino, or Spanish origin and the African American did not fare as well. And when they went in and were sick, they tended to not stay hospitalized as long. And and this is just what the numbers say, and that their complaints tended to be minimized, which really troubles me. But I read that in more than one place. They tended to be minimize more than if you and I were to go in and say, I'm really having shortness of breath. They tended to be, if they looked different than you and I looked, they tended to be not as believable as what you and I would have been just based on our appearance. And that troubles me. That's in the United States. That's in the
Oh,
United States. Um, Something else that I just found out, you want to know what I just found out about COVID? This
yes.
really troubles me. I didn't believe this. I was just told this like 2 days ago, and the person who told me, I said, That's not true." And apparently it is true. So do you know what the average life expectancy is in the United States right now? What would you guess it is? This is chasing a little bunny. You all are just going to have to indulge me a minute.
Okay. 78.
Well, you're pretty close. So, it used to be in the 80s, right? Did you know it used to be in the 80s? It used to be in the 80s, low
Yeah.
80s. So in Canada and in Britain, it is in the 80s. The
Okay.
United States, as one of the most developed countries, we have not rallied since COVID. So the average life so with all of this stuff, with all this data from COVID, we have not rallied. Our country has not rallied since COVID. So the
Hmm.
average life expectancy in our country is 76.
Oh,
That makes me a little uncomfortable.
I know. I thought I heard something about this the other day, and I was a little surprised too to hear
Yes,
a number in the 70s.
yes. It has to do with still immunizations and again, I'm not getting into all of that. This is just what the data, I mean, we do have data that looks behind all of this. Um, And, again, I urge everybody to go in and you dig whatever data you want to believe, but you need to go in and take a look at all of that. We do all have science degrees. Everybody who will watch this has science degrees. Um, Very interesting that we have not rallied since COVID. So this is CMS looking at, again, cultural differences. And the only thing that I can think of why they would be looking at just Hispanic, because this came out in 2022. So at this point, we had 2 years of data after COVID, and we know something about African American, but we don't have as much data on the Hispanic, Latino, and Spanish culture. So that's my guess. I don't know. They don't say. That's just my guess. So as
That's a
I
good
dug,
guess.
huh?
I said I think that makes sense.
Well, it makes sense to me, but I can't say that definitively, but that's just my guess. I don't know. Um, but I think it's interesting. And again, this came out in 2022. So it's 2 years after COVID. And COVID definitely changed our landscape. It changed the world's landscape. It changed healthcare. And it should change the questions we ask about what we do and the outcomes. It should change what we do because so many people died. The plague that happened, back in the 20s, it should change how we look at medicine and how we practice and wellness. Someone asked me something the other day about, well, why would you do that? I said, it's called preventative medicine. That's why you would do it. Yeah, I want to keep people well. I want to be proactive. That's the whole reason I would do this. It's like, why would you be asking me that question? It's called preventative medicine. It's like, oh, I didn't think about that. It's like, you know, so we should be, this is my opportunity to tell you guys, don't just go into these things and just don't become technicians. Think about these things. And Stephanie, when you see a question like that, don't be content with just, I know life gets busy, but don't be content with just saying, I wonder why that is. Go in and dig and find out, why are they just asking me about this? I wonder what this is all about.
That's a
And what
very good point.
and what do I need to take from this? Because you're a nurse and we need nurses to be thinking. We need you guys to use the training that you have and interpret the information and what you learned in school. We don't want we need you to be thinking, is all I'm going to say. We just need you to be thinking. We need all of us to be thinking. Okay? So how about race? So look what they did for race. This is really interesting too. So race used to be just, like maybe four or five little questions, four or five little choices. And this is used again to track health disparities, which again is social determinants of health. And now look how many they have. I don't even know where some of these are from, to be honest. And now what they're saying is a patient with severe dementia or unable to respond, um, the caregiver states that the patient is African American and Korean. This is what you would mark. Because again, you're checking all that apply. So you're going to mark an X, a B, and an H. You mark all that apply. Now, I find this interesting. Now, these are just my 2 cents. So it's interesting. I think my own opinion is race is what's in your mind, Stephanie? What's the difference between race and culture?
Well, the culture is how do I say? Like the practices of the area where you
Hmm.
live, like maybe the food that you eat, the way you respond to people,
Hmm.
traditions, beliefs. Um, Usually a race kind of goes like will be like the people in that area, but maybe somebody of a race is not still in that culture. They maybe
Okay, now,
they
okay,
are
now
in a different
you're
culture.
using the word culture. I want you to just tell me about race.
Oh, I thought you said something about culture too.
Did I what tell me about well, did I? Maybe I did. So tell me about race first. How would you okay, maybe I did. The difference between race and culture. So what is
Yeah,
race?
yeah, so race is like I don't know. It's always hard for me to understand the difference between race and ethnicity.
Mm-hmm.
I don't really know how to put it into words. Race where you I know culture,
Okay, well,
but
how would
I
you define?
guess
I mean, I'm
race
not
would
laughing
be
at
like
you.
I don't know, I just
I'm laughing with
consider
you.
it
I'm
like
not
where the area of which like or where you live. I don't know.
And I'm not
Black,
laughing.
white, Hispanic.
Well, they
Um,
have white down here.
I know, I don't know. I don't get it. It's hard for me to answer that question.
And I'm not laughing at you. I'm laughing with you because it is kind of tricky. Okay.
Yeah.
So I know how I would answer. Okay, so let's look up here a minute. So I know how I would answer. I'm gonna look it up for just a minute here. I know we're chasing a little bunny here. Race is a categorization of humans based on shared physical or social qualities. Okay. What is race versus ethnicity? Race is a social construct based on your physical traits, while ethnicity is based on cultural characteristics. So race can be used to describe your geographic. It can involve cultural, religious, or national groups. It can be. Um, but it's usually based on your physical traits like your skin color. I always think of I always think of race as being more how you look, although it can be based on where you're from, like someone who's Vietnamese is going to be from Vietnam or the Vietnam area, but yet they can be Vietnamese and have certain characteristics from being raised from there that doesn't necessarily bind them to staying in that area. Does that make sense? Whereas I have someone who's Jewish, I have a good friend of mine who's Jewish. That's not his race, although he looks very Jewish, but that's cultural. But yet it does impact his appearance as well. So isn't that kind of interesting?
Yes.
I just think that's all kind of interesting. But they talk about ethnicity because, see, and it's interesting just because we're gathering data on it. So, what are we even gathering data on it? Race is a categorization of humans based on shared physical or social qualities into groups generally viewed as distinct within a given society. That's race. I don't know.
It's
And that's,
confusing a little. I mean, I
yeah,
think I get it.
yeah.
It's really hard to explain.
Well, I think ethnicity is, and I think the interesting thing is if some of this is based on your appearance, because some of these things we can tell, like if someone's African American, we can tell by looking at them that they're African American to some extent.
Yeah.
Is this so important? And yet, health disparities, they've expanded these groups to track health disparities. So, what could we conclude from this?
That we have more races now living that we're treating.
Or perhaps that disparities based on how somebody looks, there are disparities in their health and perhaps in the delivery of services they get based on their appearance. Because this is all based on primarily, we said race is a lot of this is you could tell. I mean, you could tell somebody who's if you know, like I had a neighbor who was Chinese versus I've worked very hard to understand the difference between Chinese versus Japanese versus Vietnamese. And of course, I love the languages, so I'm always nosy and asking people, what language are you speaking? Because I love languages. Um, I have someone who's from Guam. I have a good friend from Guam now. Um, my daughter is dating someone who's a Pacific Islander. And so I'm really trying to pay close attention to understand what the differences are. And there are differences in appearance that you can tell just by looking at them physically. And I find that very interesting that they would all call that race, and they're using it to track health disparities based on just someone's appearance. And who's delivering that health care? But we are. Stephanie, you and I are. That makes me kind of twinge. And again, we are the front line of going out and providing care to those people in the outlying areas. And I had a patient who, and I'll never forget this, very wealthy family. I'm not going to give too much information other than just to say it was somewhere here in Gainesville. And the husband at one point said to me, "Do you know who my wife is?" And I said, well, I haven't. Yes, but do you know who she is? And in my mind, I'm thinking, that doesn't matter to me because I'm going to treat her just like I do everybody else. And I'm going to take care of her and going to give her what she needs, just like I do the patients that live an hour outside of town and have chickens running through their house. And we need to be sure that we do the same thing. You know, we talk about VIP patients, and we should be thinking that all of our patients should be VIP patients. I mean, we talk about it and you're going to say, this is a VIP patient. But I don't even like that term because we should be looking at all of our patients. There should not be preferential treatment based on somebody's race, based on who they are, what they do. If they're a bigwig physician at the university, we should, all of our patients deserve to have, whether it's your grandma or my grandma or the president of the university or somebody who has chickens running through their house, they all deserve to get excellent care from us. And I think that's part of why I wanted to have this conversation is I think it's worth it. We're collecting data on all of this, but I think that's the heart behind all of this. Okay,
Yeah.
let's move on. One of the things that they added in, and I'm trying not to skip pages, this keeps jumping, and I want to make sure that I haven't missed anything. I could always, I guess, look in my book to make sure that it's not jumping. So one of the things that CMS changed when they did this version, not the E1, but the E, is they changed the language. You can see it has a letter A before it. They did this again for health disparities. They want to be sure that we're presenting and teaching in the patient's preferred language, and they changed this to be preferred language, and it's a write-in instead of it used to just be a few selected boxes. We know that we have a language interpreter service. We talked about that when we did the policies and procedures. And there are 123, I think, different languages in our language interpreter service that we have access to. And this is what is your preferred language that we write in. And then do you want or need an interpreter? And this does include American Sign Language. And you may obtain this from either the patient, from a patient, a proxy, or medical records. Um, and if English is not their preferred language, we really need to look at whether or not we need to get a proxy in for them. Okay. And again, I'm going to skip some of these questions. They call this the Mu 90. When you do this, you might notice that symmetry will change. The symmetry is the name of the company that scrubs our data and goes in and makes changes. This is the date that ideally we would say that it's going to be the same date that you're completing your Oasis assessment. I mean, that you're completing your face-to-face assessment, but that may not necessarily be the case. CMS has intentionally made this assessment so they want you to have to be able to collaborate with your peers. And so really, this is going to be the date that you are last inputting information into this assessment, this Oasis assessment. Um, Let me make a caveat, and if you need to highlight this, if you are late doing your discharge assessment, bear in mind it is supposed to be done. The Oasis assessment is supposed to be done within 48 hours of discharging the patient. However, if someone is late, you didn't know you needed to discharge them or whatever, and the cert period is already ended, this discharge cannot be completed after the end of the cert period. You have to backdate it, and it has to be done within the cert period itself. So let me repeat that again. The Oasis assessment cannot be done, cannot be completed, even though I just told you this is the date you're actually completing the Oasis, but it cannot be done after the cert period has ended. In that case, you have to backdate it so it's done within the cert period itself. Oops, CMS changed this. I'm sorry, it jumped. Nah, sorry about that. My computer has a mind of its own. Okay, I'm trying to get it down here. Let's see if I can get it to stay. Trying to show you this question down here at the bottom. Date assessment, nope, M0100. Let's see if I can get it to stay long enough that I can cover it for you. Want to go over that bottom? Keep it right there. Okay. The start of care is pretty straightforward. Notice these numbers are not, they don't go along. We're missing number 2, 4, 5, 6, 7, probably because there was a number 2 at one point, but that got changed for some reason. Um, this is the one that I want to point out to you. So these are pretty straightforward. The start of care is always going to be, and the reason this is important to know is because usually the questions will be embedded into your assessment, but on some occasions you have to select those yourself. And when you do, every data set is not the same for every assessment. So you want to be sure that you're always completing the correct assessment for what you're wanting. So the start of care is just what you would think it is. It's the start of care. The resumption of care is the rock. The recert is after you have used up all of your visits and you need another 60 days. I've just heard it pronounced as a SCIC, and I like that better than the way I was pronouncing it, as the significant change in condition. This is one we don't do nearly enough, and we should do it more. This is when, for example, we have some patients who have diseases and disorders that they are not going to get better from, that are terminal. And if you have someone who is not, if it's progressive, they've not gone in the hospital, someone who is dying, who is declining, our outcomes go from point A to point B. So usually they go from the start of care to discharge. But if you have someone who is declining, but they're not hospitalized, it would be wise to do an Oasis. You can create it. It's across the top to go in and create a number 5 other follow-up to capture, to somehow explain what's going on with that person. Because then instead of going all the way back to the start of care and measuring those outcomes from the very beginning to the end, now that's going to become the new part, the new comparison part from that significant change in condition to the end. So now our outcomes are only going to be measured from here to here. And otherwise, if you don't, and you go all the way back to the beginning, um, it appears as though we're making that person sicker. So this gives us an opportunity to explain what's going on with them. So just keep that in mind. Again, we don't do it, but anytime you have a person say they have terminal cancer and they're getting sicker, um, oftentimes when I'm going through and doing chart audits, and I'll go through and look at the Oasis and I'll say, gosh, is this really accurate? The person is declining. And they'll say, or I'll look at something, they'll say, yeah, they're really declining. Well, why don't you go ahead and do an Oasis so we can capture some of this data? So we have a way of explaining why they're declining. And so that's really kind of what that's all about. Okay.
So
Then you
where
have
do we find that? Like within the patient's chart? Is that an option?
it's so when you go across the top, it's one of the tabs across the top, just like you have the services tab and the
Okay.
communications. There's an Oasis tab, and then you would just have to select a number 5 and other follow-up.
Okay. 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 I
And
know what
that's
you're
the
talking about. I think
and
we did
that's
that
the
yesterday, something similar.
yes, and that's the only thing that ever is if the SCIC is only an other follow-up. That's the only reason you would choose that.
Okay.
Okay. A number 6 is when it's transferred to an inpatient facility, but you're not discharging them, versus a 7 when you are discharging them. And so that's something that you just kind of have to decide based on if somebody goes into the hospital, um, kind of where it is in the certification period. If it's toward the beginning of the 60 days, you're probably going to want to not discharge them. We can also go into Epic and look and see what's gone on with them. If it's toward the end of the cert period, you might want to discharge them depending on, sometimes you can tell whether they're going to be in there for a longer period of time or not. When in doubt, you can call the PCM, the case manager, to see what they would recommend. Should we go ahead and transfer this patient or not? Um, it's sometimes you kind of have to use your judgment to see what you need to do with that. It's nice to not discharge them if you don't think that you would have to, because that way you don't have to do a whole nother start of care, but sometimes you have to. So you just, again, when in doubt, just call and ask your manager. But sometimes if it's toward the beginning of the start of care and they go back in the hospital, a lot of times you don't discharge them. You're just going to go ahead and do a transfer and wait till they come out, and then you'll just do a rock. And that's in that case when you do a rock. Okay. And then you have 2 discharges from agency. One is a death at home. And the conditions for this one is if they're discharged less than 24 hours after they're admitted, um, if they die in the ED, if they die um, before they're treated in the ED, if they die at home, or if they die in outpatient surgery, then you would select a number 8 and you'd call it a death at home, versus doing a discharge from agency when it's just a planned discharge from the agency, which is a number 9. And again, the importance is because each one of these are going to ask a different set of questions. And remember the conditions for a transfer, when we talked about a transfer, which would be up here, the 6 and 7 is they're admitted to the hospital for 2 midnights for reasons other than just diagnostic tests. And the transfer date is the date that they're admitted, not the date that they're transported to the ED. Okay? Any
Okay.
any questions so far?
I don't think so.
Okay. That jumped. Hang on. Oh, didn't jump. Good, good, good. Okay. So we had some questions that went away. Gosh, hang on. I'll make sure this isn't jumping. So we did that. Gosh, which way is it going? Did that. Come on. Okay. So this was what we talked about. Um, so when we talked about late start of care, this was the date of the physician ordered start of care and the date of referral. This is that M0102. This is the question. It looks better in the context of the question. It's kind of hard to tell where it is from here, but this is the question that you would have changed. If you start the start of care beyond the referral date, you have a referral date here. And if it's more than 48 hours later, then you're going to have to go in and change this date. And that's if you look back in your start of care date in your manual, it's a little bit clearer to see than when you're looking at it just from here. But these are the dates. These are the dates here that you would change here. Okay. Not very clear to see on this. In fact, pretty hard to see on this. Okay. This is a new question that was added in, the transportation question. This is one of the social determinants of health. Has lack of transportation kept you from medical appointments, meetings, work, or from getting things that you need from daily living? Um, Again, this is taken from the national community. Interestingly, some of these tests that have been added in are from community assessments. Again, because one thing that CMS is trying to do is they're trying to get us to look more across the whole spectrum of care, including community health departments, which I find very interesting. We forget that they even exist, but they certainly do exist, and they're taking care of the patients just like we are. So this is also important because this is also in part of our head to toe assessment as well. Okay, let's see, what other one do we need to go take a look at? These were all new questions. Um, Discharge disposition, I want to talk about. Um, in most cases, discharge disposition is going to be a 1. Patient remained in the community without skilled services for a Medicare certified home health aide. That's even if the patient is going to outpatient therapy. Um, in most cases, it's going to be a 1. They're remaining in the community without skilled services, even if they have a skilled caregiver staying with them 24/7. That's going to be a 1. The only time you're going to select a 2 is if the person is either being transferred to, like, say they're moving, and they're going to another Medicare licensed home health agency, or, and you might want to make a note of this, we've had a lot of people this month we're having to discharge and readmit them because they're changing insurance providers. Some of the Medicare providers, I'll just say they're less than candidate. How about that? They're less than candidate in getting people to sign up. And a lot of people signed up and are finding that it's not what they thought they were signing up for. So they're switching back. So we've had a lot of people who've been switching back. And when they do that, we have to discharge them and readmit them under their new carriers. And when we readmit them, we're readmitting them to us, and we are a skilled Medicare provider. And so in that case, they would be a 2. Patient is remaining in the community with a skilled service from a Medicare certified home health agency, and that's us. So any of the cases where you have someone and you're discharging them and to readmit them because they just changed their insurance provider, then that's going to be a 2 when they're staying with us. Okay? Otherwise, in most cases, it's going to be a 1. Okay? We do always give reconciled lists to the providers. So those are always yes. We always give them a discharge, yes. Always, they always have to be HIPAA compliant. Believe it or not, we always give them on paper because we print them. And let's talk a little bit about what happens. So these are new. Provision of reconciled medication list to the patient at discharge, yes. They also have to be HIPAA compliant. Remember, we did that whole discharge paper when we talked about the discharge? Oops, sorry. And that's done paper-based because we leave a copy of the medications in their home folder at all time. And that's what is the paper-based copy. That's what we're leaving in their home. So we're going to leave them a paper-based copy at all time. So that's what we leave in the home. And we do a
Okay.
hands-on reconciliation. Okay. Hearing, speech, and vision. I'm sorry, this keeps jumping. This is just making me nuts. So this goes along, these are the Oasis questions that go along with your head to toe assessment with the hearing. Rather than just saying, do you hear okay? I would ask them, do you have any kind of hearing aid? Do you have any trouble hearing in any kind of environments? There are a lot of boomers who need to have some kind of assistance and they just don't want to wear it. They're embarrassed. So I would ask a few questions to see if they have anything, because if they have something, they're going to have it because they should be wearing it. For the vision, you're not only looking at can they see, but can they see well enough to understand? Um, and I would do this with their medication reconciliation to see if they're able to help a little bit with seeing their medication labels to be able to help you to be able to reconcile the medications. And with health literacy, how often do you need to have someone help you when you read instructions, pamphlets, and other written material? This is taken from the single item literacy screener. So when you do your head to toe assessment under the top part under oh gosh, what part is that? The communication and learning, it asks you, did you do a test of health literacy? The question is yes. And when you select yes, it's going to say, what is the name of the test you did? The single item literacy screener. And what were the results? Patient reported, and whatever of these they reported, they sometimes need assistance with health material. They rarely need assistance with health material. They often need assistance. Whatever they reported is what you're going to put on there. Okay?
Okay.
So don't leave that part blank in your assessment up above. So answer these questions first and then go up and put it up above in your head to toe assessment. Okay?
Okay.
This is the cognitive part of the BIMS. You're supposed to do the BIMS and they expect you to attempt to conduct it with all patients unless they're absolutely unable to respond to you. You're supposed to do it with all patients. And so this would be a yes. And really what you're doing with them is you're looking at their immediate memory here, where you're going to give them 3 words and they say them back to you. And I should have given you the cards for the BIMs in the first email that I gave you. Then you're going to be looking at the temporal orientation, and I kind of showed you this a little bit when we did the documentation. What month, day of the week?
Oh, yes, I remember that.
Yes, and then you're looking at their short term, their working memory,
Hmm.
and then you add it up and you're getting a total score. And then in here, I give you on the bottom of page 8 out of 35, I give you how to interpret the score. So that's what I would put on your page for your cognitive. I put BIM's score of 12, moderate impairment. You don't need to put all of it, and then you can kind of fill in some of the information from the BIMs because they give you a working memory, they give you an immediate recall, they give you attention, focus, ability to shift attention. They give you all kinds of information you can glean from this BIMS. Okay?
Okay.
Signs and symptoms of delirium. Again, they're wanting you to look at this. That's the CAM. You're looking at inattention, disorganized thinking. Patient is usually noisy or belligerent and becomes quiet. A lot of these go along with this risk for hospitalization, the decline in mental or emotional behavioral status. Some of this you might have to talk to the family. Is this how they usually are? You might see some of these changes with the UTI. You might see some changes with behavior. And so I had someone come in shortly after we had the BIMS and they said, they were really proud. They said, hey, guess what I did? And I said, what? And I said, I went in to see my patient on Monday morning and the husband said to me, something happened over the weekend. She's acting really different. She goes, so I took out the BIMS and I gave her the BIMS and sure enough, she scored differently from how she did at start of care. So she called the doctor and said, I just wanted you to be aware that we gave the BIMS at start of care. The patient scored a 15 out of 15. I gave it to her today and she only scored a 7 out of 12. Something is going on. And that way you can give her some standardized assessment rather than just saying she doesn't seem to be quite as alert and oriented. And they said, oh, wow, okay. And they got her in right away. So see, use these tests. They can be given at the time points, but it only takes like 3, 4 minutes to give. And then when you call the doctor, you actually have some standardized assessment that makes sense to everybody. You've got some scores that you can give them. So that just keep in mind that you have these, you've got them on cards. I would recommend that you put them on your desktop so you have them. I'm going to give you that's why I gave you the flip cards that you can always do them at any point in time. You don't have to do them as part of a full Oasis assessment. And you can always have the scores in case something happens, which happens all the times through the course of treatment with somebody. So keep that in mind that you have it. And these are the cognitive functions. These are the old questions that go along with them. M1700, you have to look beyond alert and oriented. This also looks at their ability to comprehend and recall task directions independently. Number 1, this is most of our patients requiring prompting, cueing, repetitions, stressful or unfamiliar conditions. Being admitted to home care is an unfamiliar condition requiring assistance, cueing, um, shifting attention, low stimulus environment. If you see them yourself wanting to turn off the TV, asking the grandkids to leave the room, if you find yourself wanting to modify the environment, most of our patients, our older patients, are not going to be a 0. A 0 is you and I. We're a 0. Most older people have trouble shifting attention. They look to their families to help them. If you find yourself repeating yourself, just giving them a little bit of cues, that's a 1. And there's no shame in just giving them a 1. Most older people don't understand information quite as quickly. So if you find yourself talking more slowly, that's maybe requiring assistance or requiring prompting. And that's all this is looking at. This is looking at if they're ever confused. And mind you, this is in the last 14 days. And this is when anxious in the last 14 days. So note, be sure that you pay attention to those time frames. We're so accustomed in the hospital, alert and oriented times three, bam, they're alert and oriented, and we go on. If you have a patient who is needing the family to be in there to provide supervision to them, then they're not going to be a zero. Okay, so keep that in mind. That's a lot of our patients. And we miss these all the time. And we shoot ourselves in the foot because this speaks to the complexity of our patients and why they need us to go in and repeat things and why they're not able to get their medications one time and have it. And yet we say that they're alert and oriented and they've got it. So be sure that you're paying attention to these things. And so now it won't change pages. This is driving me nuts today. There we go. All right. Here's another one for mood. Okay. This is the PHQ 2 to 9. This is for um this goes along with depression. And I would do this when we have a section in our head to toe on depression. Again, I would start down here with the mood PHQ 2 to 9. And if they do well with A and B, then you don't need to complete the whole test. And then what you do is you get a severity score. And if they do really well, then I would go back to the top. PHQ 2 to 9, score of 0, no indication of depression or anxiety. I think it's depression. And I give you the scores for that as well. Yeah, minimal depression or no depression. Okay. So again, you want to interpret those numbers. Don't just list them out, interpret them. I've given you all the interpretations right here so you have them. You have a thing on social isolation as well. Total severity scores, you've got all of those. If they report sometimes feeling isolated, bring in a social worker. There's not a whole lot that you or I, as a speech pathologist or a nurse, can necessarily do about that. But that's why we have social workers. Both offices have social workers, and that's why we want to rely on our team to help us with some of these things. And there's the interpretations I have down there for you. Okay. All right. Let's talk about these a little bit. Okay. So the M1740. Don't get stuck on psychiatric symptoms. These are just cognitive or behavioral. So memory deficit, part of it is, yes, the failure to recognize familiar persons or places. Don't get stuck on that. Inability to recall events of the past 24 hours or significant memory loss so that supervision is required. Again, if the person is having trouble with their memory, so that the family doesn't feel safe leaving them alone, then that's going to be checked. If they have impaired decision making, and notice the first example, failure to perform usual ADLs or IADLs. This is someone who, it's not that they can't get dressed because they have a frozen shoulder, but someone who is forgetful. They can't line up their buttons anymore. They need assistance because they don't really remember how to get dressed. They need assistance brushing their teeth. They push their walker to the side and walk without it. CMS considers needing to provide assistance to help somebody get dressed as being disruptive to the family. And if you've ever needed to take care of a parent, we have several nurses in the Gainesville office who are caring for a parent right now. It's very disruptive. And that's all this is talking about. And then some of these, as you go along, these are the more severe, the verbal disruption with the yelling and the threatening, physical aggression, but these top two are not that severe. We have a lot of patients who have need supervision, who can't get dressed. They have problems with ADLs. They can't do their finances anymore. They can't manage their bills. That's what this is talking about. That's impaired decision making. When my mom passed away, she had 3 life alerts. And then if they have problems here, then they're going to have problems here. If someone has a cognitive impairment, they have a memory problem, they have dementia, anything at all, then they're probably going to be at least daily here. They're going to be a 5. Okay.
Okay.
1745 says how often 1740 occurs. These two go together. So make a note of that. These two go together. Watch the consistency with those functional deficits. If they need assistance with the ADLs and the IADLs, the personal relationships, the difficulty with independence. CMS considers sundowning, wandering, agitation, aggression, combativeness, getting lost in familiar places as disruptive behaviors. There's another question, I think it's 2102. We're going to get to it where it talks about the level of assistance for the caregivers. If they need assistance here, then those items are going to need assistance as well. So when we get to those items, it's 20, and in fact it is 2102. It's just a little bit further down the page. Those are going to tie in with these as well. So if they need assistance here, they're going to need assistance with those as well. And I'll point those out in just a minute. So any assistance they need with here, they're going to need assistance there too. Okay, so here we're talking about their living situation. So this is a 2-step question that you have to answer. I answered this wrong for years before I figured out how to answer it correctly. So first of all, you have to look at their living arrangement and you look at it down this way. So they either live alone, they live with somebody else in their home, or they live in a congregate situation. So here's what CMS says. If they have a caregiver living in the home 24/7, but that caregiver is a paid caregiver who's not a family member, the patient still lives alone. And they're going to be this row right here. I have someone sticking their tongue out at me. Such maturity in this office. This row right here. Okay. If that caregiver is a paid caregiver, but it's a family member, they live with another person in the home. And it's going to be this row right here. Okay. If the person, and we have this a lot in both offices, lives on family property, and everybody lives on the same piece of land, but they have their own homes, the patient lives alone. And that would be with occasional short-term assistance. Okay. If they live in an assisted living facility, a congregate living assistance, a congregate living, like a residential care home, that would be here, 11 through 15. But if they live in a place where it's all like adult apartments, but they're all independent apartments, then the person lives alone. It's all up here. Okay.
Okay.
Once you decide this, then you decide whether they have around the clock care, whether they have regular daytime, which means they're there during the day, but not, so that would be somebody who works the night shift, whether they're there at night, but not during the day, whether they're short term, like maybe somebody from their church comes in and brings something, or their kids come in during the day, or they have no assistance available at all. So say, for example, we have um, a couple living together, but both of those both of those people are our patients, which we have a lot of situations like that. Say one of the patients has Parkinson's and they're wheelchair bound and pretty impaired, and then their caregiver, their spouse, just had something happen to them and they've now become our patient as well. It could be a B situation and it could be a number 10. If you go into a situation and the patient is living with and surrounded by all of their adult children, and everybody's hovering over mom and dad, the question you have to ask is this a permanent situation? Is your mom staying with you permanently? Or is she going back to her own home once she recovers? And the mom might be saying, oh, yeah, I'm going back to my own home. And the adult children might be saying, then you say, well, is her home on the market for sale? And it's like, well, no. Then you're going to mark it as the patient lives alone because you're going to be teaching very differently to someone who might be going back to her own home by herself versus someone who's going to be staying in that environment where she's has a lot of assistance available. And that totally makes sense.
Yeah.
So I never knew to ask. I just went in and assumed, oh, they've got all these people around to help without even asking, oh, is this a permanent situation or just while Mr. Brown's recovering?
Right.
You always have to ask.
Okay.
You always have to ask. Okay. No one ever told me that.
Yeah. I was wondering that too. It's kind of hard to make those um decisions. So,
Yeah. Yeah. You have to ask. And here's the other question that relates to the questions I was just talking about. Types of assistance. So if someone needs help with ADLs or they need help with dressing, this is the only question that deals with the caregiver. And these are the questions at discharge. A lot of people make this mistake on their discharges because they'll say ADL assistance, no assistance needed. So when you go in and do a start of care, you're probably going to code about a 2. Non-agencies caregiver need training and supportive services to provide assistance because that's one of our big jobs is we go in and train the caregivers on what they need to do, right?
right.
Hopefully, at discharge, they're going to be either a 0 or a 1. No assistance needed, or non agencies caregivers currently provide assistance. But unless that person is completely independent, there's still going to be a 1 on all of these questions on the 2102 types and sources of assistance. They
Okay.
can't be a 0 if they still need help getting dressed or with their finances or getting their medications. And a lot of people get them with the medications, but they think with their ADLs and these are all the M1800 questions that we're going to get to in just a minute. And they can't be independent here too. So be careful you don't get tripped up on that.
Okay.
Okay.
All right.
And speaking of M1800s, let's stop with that. And I have another thing to share real quick. So let's swap to another document. So everybody behind your Oasis document, you should have something that looks like this. So stay in the same section, but look in the back and it says M1800. So keep something in here, but look in the back and find what says M1800's GG items in 1033 or something to that effect. Did you find it?
Oh, Sarah, I see.
And it
I
has a
do
little box and
see.
it's either green or blue.
I see a blue box. It says M18 GG item comparisons.
That's it.
Okay.
I kept changing the title. I don't even know what I ended up with. Mine says
Okay.
something different. I'm getting cold again. Now the room's starting to get cold. All right. So I want you to go ahead and read this, the bottom of page to the bottom of page one, and tell me when, Stephanie, when you're done.
Okay. Mine looks different than yours, though. Is that okay?
Let me see. Hold it up. Nope, that's not the right thing. Keep
Okay.
going.
Let me
Take
look.
go.
Oh, wait, I see.
You're too far forward.
Oh, I
Go.
see.
You
I
got
have
it?
it. It says, wait, M18 and M1033.
It could. Mine says number one on the bottom.
Yep, general item. Oh, yep, I got it. I got it.
Yep.
Okay.
Because the other thing is a PDF, so I couldn't have all the page numbers be continuous, unfortunately. So this
Okay.
is a little separate document and it should say page one.
Yes, it does.
Good.
Okay.
Okay. So go ahead and turn to the next page. So let me kind of tell you how this is laid out. So you'll see some little numbers in the corner of Gainesville and Jacksonville. Gainesville 63%, Jacksonville 38%.
Mhm.
So I started this back in 2022 or 23. I started tracking the data from both offices and their accuracy on some of these questions. And the way this works is the higher the percentages, the worse they were doing. So on this, the goal is to have 20% or less mistakes. Um, and this was and then I started, first I did it for just the offices, and then I started tracking the individual accuracy of everybody who did the Oasis. So as you guys do more and more of these, I'll actually be tracking your individual accuracy on some of these questions as well. And now some of them have changed because our payment, the M1800s are still involved, but now the GG questions have become more involved with the payments. Um, so let me give you some new numbers on these as well. So I revised them in June of 2024. So that's been almost a year ago. So now I need to get some new 2025 numbers. So Gainesville accuracy was 63%. And I actually didn't put the new Jacksonville numbers on here. I need to do that. Gainesville accuracy started at 63%, not good. But in June of 24, a year later, it had improved to 27%. So I can tell you that Jacksonville made the same kind of improvement. So basically, we cut the mistakes in two-thirds. We were making two-thirds the mistakes. So instead of making 63% of mistakes, we were only making 27%. So we were almost down to criteria on this question.
Pretty good improvement.
Very good improvement. So for grooming M1800 M1810 and M1820. I'm going to kind of teach these three questions together because for these three, they have similar scoring. And unfortunately or fortunately, the accuracy is still important on these questions because they still count for our overall scoring. And they keep telling us these questions were going to go away, but they haven't gone away. And they've got to be consistent with the GG questions, which we're going to do next. So we still have to go over them. So grooming for these questions, the only thing for all of these M1800 questions that counts is if the item is not included in the question, CMS doesn't want to know about it. So grooming is the current ability to tend safely to personal hygiene need, specifically washing the face and hands, hair care, shaving and makeup, teeth or dental care, or fingernail care. So if it's not listed in that list of things, then CMS does not want to care about it. It gives you the list of scoring, and in some cases, it's not too complicated. In some cases, the way that they word it is so complicated that I'm going to give you a different way to use the scoring that's not quite so complicated.
Okay.
And for each of these, the important thing to know about these questions, all of the questions for Oasis, you're always looking at safety, safety, safety. It's
Okay.
always depending on what level the patient is able to do safely. And you're always considering the intent of the question. And you're not judging it based on the device that they use. You're judging it or coding it based on the level that they would be able to do it safely.
Okay.
And there's always things that you have to consider, always things you have to consider. And the way you would learn all this information again is each of these questions, there's a little eye icon right by the question. This is the actual excerpt from what you would see in Crescendo. This is the actual Oasis question, what it looks like. And the
Okay.
I stands for information. You would click on it and you would get some of this information from the actual manual. And what I've done is I'm just kind of summarizing some of it for you. So
Okay.
I want you to go ahead and read the considerations. And then Stephanie, you're going to get to do the practice questions for everybody. So those of you who are watching this, you're going to be doing the same thing. You're going to be practicing them. And I want you to be answering them as well.
Okay.
Okay, did you read the practice question?
Let me read the practice question.
Okay, tell me about Diego, what you think.
Oh, wait, I see Lucy.
Oh, you're a page ahead. Just
Oh,
M1800.
oh, sorry. Okay. Number two, I would grade him a two.
And why would you say that?
because he needs assistance getting to the bathroom.
And once he gets to the bathroom, how independent is he?
While he performs his grooming safely,
Mm-hmm.
standing and sitting. So it seems like once he gets there, he can do it on his own,
Mm-hmm.
but he needs help getting there.
Okay.
So I guess, and then if he needs us, then he must have assistance
Okay.
because he can't groom himself without getting there.
Correct. So, what does it say about if he's independent but only needs help with assistance?
Um,
If he's otherwise independent, if he's independent, he would be a what?
0,
He'd be a zero. But if he needs help with access, he's a what? It drops him down to a what?
a 1.
It drops him down to a one.
Okay.
And that would be his score.
Okay.
Right, good. Okay. Now let's go over to M1810 and M1820. So these are scored the same way. These are scored M1800, M1810, and M1820. And another thing I forgot to tell you about M1800 is these three questions are also scored according to the majority of tasks. You read it. So the majority of tasks is where you need to count the tasks, you count how often they occur, and then you actually score according to the majority. So something that occurs only once in a blue moon is not going to have as much impact on somebody's functional abilities as something they have to be able to do every single day, right?
Mm-hmm.
So, for example, a man who doesn't shave his whiskers is not going to be as impacted by his inability to shave if he doesn't shave
Mm-hmm.
versus if he can't brush his teeth. We would hope.
Right.
We would hope. Okay. So that's why you actually count how often they happen during the day, how many times he does it, and then you find out you actually count them and there's no averaging. You actually count them. Okay. So M1800, M1810, and M1820, all of them, you're looking at just again, you're looking at just the skills that are listed there, including the undergarments, pullovers, front buttoning shirts and blouses, managing zips, buttons, and snaps. For the lower extremity, you're looking with or without dressing aids, including undergarments, slacks, socks or nylons, and shoes. You're looking at access and you're looking at majority of tasks. Okay, again, mistakes have been cut nearly in half, um, a little bit less than half. So people have done really well understanding the questions better.
Mm-hmm.
Lots of considerations you have to read for both of these. And then let's go ahead and answer the question about Lucy.
Okay.
Take your time. We're not in a hurry for this. All of these questions are not an interview. The Oasis is a show me. It's an assessment. It's not an interview. When you
Okay.
attempt to interview, you're gonna get yourself in trouble and make mistakes.
Okay.
Here's the two questions. Jumps.
Probably 2.
And why do you say that?
Because if she needs help adjusting her garments so she doesn't sit on them when she's toileting, then she might not have the balance or coordination to get her pantyhose or shoes tight or
And what does the two say? What is
two
read
says
what it
someone
says.
must help the patient put on undergarments, socks, or nylons and shoes.
Right. And that's simply what it says. That's adjusting, right? Someone
Yeah.
must help her. Yeah, I'm not trying to trick you at all on these. Not at all.
Okay. They are kind of
Okay.
tricky though. I actually tried filling one of these out the other day with the nurse I was riding with,
Yeah.
and it
Yeah.
was pretty tricky.
They are, but once you do them, then you start kind of getting used to the lingo on them. And they're just as tricky once you're with the patients are never just real clean cut. It's never cut and dry. Never. I
Yeah.
mean, so yeah, that's exactly right. Okay. So let's turn the page. Let's take a look at bathing. Okay. So bathing. So bathing is the current ability to wash the entire body safely. It excludes grooming, which is washing the face, washing the hands, and shampooing the hair because we just did grooming, right? That was the M1800. Now, I think this is a lot of goop. It's a little harder to understand. CMS could have written this a whole lot clearer, but they didn't. So I did you all a favor and I wrote it real clear for you. All right. So if you're trying to make a decision about it, use my guidance, and this will help you a lot. So what I did, and I didn't do it here, but I did it on my book, I actually drew a line between 3 and 4. I drew a line here, and I drew a line between 5 and 6. And here's why I did it. 0, 1, 2, and 3 is if the person's in the shower. It's really pretty easy to decide these. If the person can get in the shower, they're a 0, 1, 2, or 3. If they cannot get in the shower, they might be a 4 or a 5. So they're bathing at a sink, chair, or commode, depending on needing no assistance or requiring either intermittent or continuous assistance. And then number 6 is they are completely dependent. They can't do either one. Okay? So if they're getting in the shower, they're a 0, 1, 2, 3. A 4 or 5 is when they're using either a basin or a sink or whatever, and depending on how much assistance they need. And then a 6 is when they are totally dependent. That's a lot clearer than all of this.
Yeah.
Okay, I think. Okay,
Yep.
read the considerations and then see if you can figure out what the answer would be for Tom.
Okay.
Now, I'm not trying to trick you. Just be sure that you apply everything.
Okay. Well, I guess I'm gonna say a 5
And why would you say a 5?
because he needs help washing his hair, and there's no shower, so that they're using a different way to bathe.
Okay. What does it say up at the very top under the question for bathing? Read the question for me.
You mean about Tom?
Yeah. No, what does it say for the stipulation for the question? It says M1830 bathing.
Okay. Current ability to wash entire body safely excludes grooming, washing face, washing hands, oh, and shampooing hair. Current ability to wash face excludes washing hair. Okay.
I'm not
Um,
trying to trick you.
well, no, I didn't see that. So are you like, are you can't score this then? Or do you have to say that it's unable to participate? I'm not sure. This is a little tricky.
Well, so what would you do in this case?
Okay, let me read it a little bit more.
Sure.
Oh, number four.
It is number four. Why?
Yeah, because it says you can that they're able to use the sink.
Okay.
Yeah.
What if he wasn't, what if he didn't have the kitchen sink? Boy, that'd be a good one, wouldn't it?
Yes. Would it be, oh wait, hold on.
Now, see, I asked that question. We'd have to debate that one. I'm not sure about that one either. So what it says, what CMS says is if they're not able to demonstrate what they would do, then you can't assume it. So, like if someone meets you at the door and you can see they're walking, they're ambulatory, they're very independent, but they can't demonstrate because they have a bunch of crap that they're storing in their shower. They can't demonstrate to you that they can step in and out of their shower. They can't demonstrate to you that they could get up and down from their commode because, and we had this happen actually last year. What do I do if there's no toilet in the house? I don't even want to know what that person is doing to go to the bathroom, but the person did not have a toilet in their house. But they have to be able to demonstrate to you that they can get up and down from the toilet. We cannot assume they could just because they're walking around in their house. They have to be able to demonstrate to you that they could have the ability to do the simulated activity. Well, I put that in that he's using a kitchen sink to wash up. So he's able to wash himself because he's using a kitchen sink. So that's a four and not a five. Um, I think if he didn't, because bathing is the process of turning on the water and doing all that other stuff. They have and is bathed totally by another person, but unable to participate effectively in bathing. I bet you if he didn't even have a sink, if they didn't have all that, I'll bet you CMS would want us to mark that as a six. Because historically, what they have said is if there's not any working plumbing or anything like that in the house, you can't assume and you'd mark it as a six, is what they've said.
Okay.
That would be my guess.
Well, they're unable to participate.
Yeah, because it's not in the house. If there's no working toilet and they can't show you that they can get up and down and do what they need to do, then that's what you would mark as well. But in this case, I said they're using the kitchen sink.
Okay.
And you're going to see all kinds of things in home care. I'm telling you, you're going to see it. So you just want to ask them, so what are you doing to bathe? You'd have to ask them.
Okay.
Again, you can't assume. You can just sometimes have to ask them. Sometimes you may not want to know the answer to the question, but you have to ask.
Okay.
Okay. All right. So here's the next one, toilet transfer. Again, um, toilet transferring is the ability to get to and from the toilet or bedside commode safely and transfer on and off. So you have to be able to access, you have to get to and from the toilet. You have to be able to get to it, so access it and get on and off. So you're looking at just getting on and off,
Mhm.
no hygiene involved, and get to and from. Okay. Um, this is also a little bit of gobbledygook, so I made this really easy for you in the coding for this one as well. When you look at their questions, 0 and 1 is they're using a toilet. A 2, they're only using a bedside commode. See, when you look at their choices, they're pretty easy. 2 is a
Right.
bedside commode. 3 and 4, they can't get to a toilet or bedside commode. They're able to place and remove a bedpan and a urinal. And a 4, they can place and remove a urinal, but need assistance with the bedpan. And that's considered totally dependent in toileting. Okay.
Okay.
So 0 and 1 is using a toilet. 2 is using a bedside commode. And 3 is using a bedpan and a urinal. Here's where they can place it. It doesn't include emptying the bedpan. And 4 is they can place and remove the urinal, but need assistance with bedpan. And in my opinion, if you've ever used a bedpan or had to use a bedpan, those can be very tricky. Even if you're in your best state of mind, if you've ever had to use one, they are very
Yeah, on
tricky.
a patient with the for a patient.
Yeah. Oh my
Yeah.
goodness. I had to use one once I had one of my kids, and it was like, oh, I'm not sure I can get this thing off. It was very tricky to be not to
Yeah.
TMI, but they can be very tricky.
Mhm.
So, but that's what the coding is. So you don't even really have to pay attention to all this. 0 1 is using a toilet, 2 is a bedside commode, and 3 is not. Okay.
Okay.
I think that's a lot easier way to think about it. But you can read the above. I mean, you can use the above if you'd rather. Okay. Read the considerations. And now we've got several questions that we need to answer. I tried to give you lots of practice.
Okay.
And we already talked about access.
Right. They have urinary catheter. Does that mean they're totally dependent? Um, yes. If they have a urinary catheter, then they are dependent. Wait. Then they're in toilet transferring. Oh, no, never mind. Well, no. Wait, do you want me to answer like each bullet?
Yeah.
So if they have a urinary catheter,
Are
they
they
would still have to
totally
show us that they can get on and off the toilet
correct? Why? What's your reasoning?
because they might have to go number two
That's
or something.
exactly right. That's exact. And this is talking about transferring, right?
Yeah.
Exactly. Totally different skill. You got it. Exactly right. Okay, what about the second one?
Number three for the second bullet,
Take a look at my guidance and
able to use bedside commode with,
see if you want to change your mind.
okay, unable to get, yeah. Able to use bedside, use resistance. Number, oh, patient can safely. Well, that one's kind of tricky because um they use a bedpan at night,
Mm-hmm.
but they can get to the toilet during
Okay.
the day. So you do you just You,
So take a look at my guidance. Did you read my guidance again?
yeah,
What does zero say?
can get to and from the toilet during the day. Oh, zero,
It's a zero.
zero.
When it's a convenience, it's allowed to be. And why do you think that is?
Because they can't see that well at night. Maybe
Yeah, and a lot of people have more urgency at night. So it could really just be, it's nothing to do with the toilet transferring again.
it's like the frequency of getting in and out and
Yeah, it
stuff.
could be a whole host of different things for people, older people getting up and down, but they're, they have that frequency and when they got to go, they got to go.
Yeah.
So just it's just a convenience that you don't want to have an accident. So yeah, I mean, there's a whole host of different reasons why that could be. So sure, just as a convenience. And what about the third bullet point?
Let's see.
Hmm.
Um, hmm. I would say we would score based upon the ability to use the bedside commode because it says he can do it safely.
Okay, so what number would you give him?
Um, number two.
You think it's a two?
Wait, let me see this again. Oh,
Remember, it's
zero?
not, remember, it's not, you don't score it based on the devices. You score based on what they're safe to do.
Okay.
So tell me what you see that's significant about this patient. Describe this patient to me.
He lives alone.
Okay.
But he can safely get to the toilet
Uh-huh.
during the day. He uses bedside commode at night because his vision. So he
But what
doesn't
hap
want to
what ha
walk across to the toilet at
but what
night.
happens at night with him though, Stephanie? What's significant what that happens at night?
Okay, well, his vision is and balance are bad, so he doesn't want to walk the distance to the toilet that he can safely do during the day. So he goes a shorter distance to the commode,
Because
the bedside commode.
what's significant that happens at night?
His vision and balance are bad, so he doesn't want to walk as far
Because what's happened?
because his vision and balance are bad and it's dark.
And what has happened as a result of that?
Oh, the falls.
He has fallen.
Yeah.
And I want to, that's real important. Anytime a patient is a fall risk and has fallen in home care, that's going to impact everything. That impacts their safety for all these questions that we've just looked at. See, I've left that out. This is the only one I've really put in there that he's a fall risk and he's fallen.
Mm-hmm.
Safety is impacted by all of these things if a person is a fall risk and if they've fallen and if they've had a fall with injury, that's going to impact the safety on all of these things. Remember, everything depends on their, so all of this impacts his safety. Okay.
Okay.
So he's fallen because of his vision problems. And at night, he has problems with his vision because he's a fall risk and he's not safe because he's falling. Okay.
Mm-hmm.
So now we know that. So I think based on that, he wouldn't be a what?
Then
What wouldn't he be?
he wouldn't be able to get there safely. He wouldn't be a zero, one, or two.
Yeah, or he absolutely wouldn't be a zero. I mean, he wouldn't
Yeah.
be during the day, but during the night, certainly he wouldn't be because he's a fall risk because he can't see.
Right.
Okay, what about a one? Could he be a one
Yes.
at night, you
Yeah,
think?
he could be a one at night.
Hmm. What about a two?
I mean, So he's a one because he is able to use the bedside commode.
Mm-hmm. Well, two is using the bedside commode.
Able to use bedside commode. Oh, I don't know what I'm reading.
That's okay.
He is able.
Do we score
Uh,
based on the use of the bedside commode or the need for supervision?
the
Which one
need
do
for
you think?
supervision because he's falling.
We that would be, I think, a greater thing than the bedside
Yeah.
commode. Right. Okay. Okay. So when you're answering these questions, you answer based on what's true more than 50% of the day and you're looking at the day of assessment or 24 hours preceding. Um, so
Uh,
what do you think would be the safest thing for him then?
a three.
Oh, now she's going down to a three.
He's unable to get there
Gonna
safely.
let him get out of bed. I don't think he's a three.
Oh my God. See, I told you this was hard for me.
Oh, that's funny. Mr. Brown, you're just staying in bed. You're not getting up.
Don't fall.
That's funny.
I don't,
I
so,
don't think he's a three. I don't think he's a three.
okay, so then a two.
I think we could argue for either a one or a two.
Okay.
I think he could argue for one or two. And in this case, when you're going to argue for one or a two, then what I might do is I might do a two at the start of care, and hopefully he would be a one at discharge. I
Okay.
think I could argue for either way. And one in doubt, I'm going to score a little more involved at the start of care
Mm-hmm.
to give him some chance to grow and to improve with our care
Okay.
at the time of discharge. And I think that's what I would go with for him because he really kind of doesn't fit either one. We're not going to judge him based on the device because we don't do that.
Mm-hmm.
Assistance, and we might also do some things like we could add in some things like some night lights for some
Mm-hmm.
adaptive things at night. That might also help him with his falls because he's having trouble because of his poor vision at night.
Mm-hmm.
He's real safe during the day, so we might be able to get him to a solid one at night if we gave him a little better lighting at night that
Mm-hmm.
wouldn't
Okay.
keep him awake. We might be able to do that with him instead of keeping the poor man in his bed.
Yeah, that's better.
You're funny. So that's kind of how I would look at it. These
Okay.
aren't hard and fast, but I think, I mean, I made up these questions, so there's no hard and fast. I think we could argue for a one or a two. Based on that
Okay.
fall risk, though, he definitely would not be a zero.
All right.
How about number five, M1850 transferring? Now, transferring, this still is not great. Transferring, we started, oops, what happened? It went all the way back to the beginning. That is just the weirdest thing. I know I hit the right button. I'm pretty sure I hit the right button. Oh, let's see. Transferring, we started out at 100% mistakes. And we're still only at 51% accuracy for Gainesville, not a whole lot better for Jax. We've continued to have a lot of trouble with these questions. This is their current ability to move safely from a bed to the chair and turn and position yourself in the bed if the patient is bedfast. So this is going from point A to point B. They have to be able to get up out of the bed and go to a chair. So that's what it's looking at. And for these things, you always want to score it before you fix it. So if the chair is in another room, getting to that chair is a part of the score. Okay. So again, I look at all of this And I think this is very confusing. So I've tried to make this a little bit easier. So a zero is you or I getting out of bed. We're safe and independent to transfer. We, I assume, don't need any assistance from a person or a device. We can just kind of hop out of bed. Okay. One is, and here's the important things we need to pay attention to. We either need a device or minimal human assistance. And that minimal human assistance, whatever the heck 25% or less is, we have to use our clinical judgment to determine that's the assistance of less than 25% of the total effort to complete the tasks. And that includes things like cues, prompts, or physical assist. And Stephanie, cues can be anything like standing next to somebody, putting my hand out as contact guard, just standing there just to make sure they're okay. I don't even have to touch them. It can be something like, okay, Mr. Brown, you got it. Be careful you put your feet on the ground. Remember to scoot your bottom out to the outside of the bed. Anything like that counts as a cue or prompt. You're using either get your walker, or he's getting his, or you're helping him with his walker, but you're not saying a word. Okay. The thing we have to watch for as clinicians, it is so ingrained with what we do, is we do all these cues and prompts and things, and we don't even realize we do it. So you really have to be mindful of the assistance that you provide. Um, and then two is requiring both. So two is when you're requiring both the cues and the prompts and the assistance. The person has to be able to both bear weight, so they have to be able to get on their feet, and they have to be able to pivot, but they're requiring more than just that minimal human assistance. And this is where we start getting any kind of payment or assistance for helping the person. Okay? And then three is when they're unable to bear weight or pivot, or bear weight and pivot. I just think that's kind of tough. And they're not bed fast. Four is bed fast, but they can turn and position themselves in bed. And five is bed fast, and they're not able to turn and position themselves in bed. So use this one because I think this one's a little bit easier for you. Okay. And go ahead and
Okay.
look at the conditions. Pay close attention to what CMS says bed fast is. And let's do the practice questions about Jalen and Jesse.
So Jalen is,
Did you read all the considerations? Did you
oh,
read all these?
no.
Yeah, you're going to want to read those first because that'll
Okay.
help you with the answers. Mhm. You can tell me about Jalen.
So Jalen is 5
And why do you say that?
because he's quadriplegic, totally dependent. He cannot turn himself in bed. Um, yeah, he cannot turn himself in bed. So,
Mm-hmm. And what is the definition of bed fast per CMS?
unable to transfer, and unable to turn or unable to turn
Is
in
that what
position.
is that what it says for the definition of bed fast per CMS?
Well, it says bedfast, unable to transfer, but is able to turn in position, or unable to transfer and is unable to turn in position.
Well, those are that's the guidance for the coding, but those aren't the definitions for what CMS says. Read the considerations.
Oh, this the patient is medically restricted to bed or unable to sit in a chair. So is it not a five?
It's not a five. Remember, this is CMS. They tell us that it is sometimes going to go contrary to our clinical training. And this is a real good example where it does. And they wrote the test so they can make us interpret it however they want.
So is it one?
He's safe and independent to transfer?
I don't know. Honestly, I'm confused. And he says it says able to transfer with an assistive device. And it says he can transfer with a Hoyer lift. So I guess I'm confused. I don't know.
Okay, so I want you to start read all the considerations carefully. I think you kind of jumped around a little bit, and I think that's what's confusing you some. So first thing I want you to answer for me is he bedfast? Let's answer that question first. Is he bedfast? A lot of people have trouble with this one. So anybody else watching this?
No, he's not
No,
bedfast.
he's not bedfast. So we've just eliminated
Oh,
0, 1, 2, and 3. Or 0,
okay.
1.
Well, that makes sense too.
We've just eliminated 4 and 5 because he's not, you said he's not bedfast, and you're correct about that. He's not bedfast. So that's really the first question you need to ask yourself is he's a quad, but according to CMS, by their definition, is he bedfast? No, he's
Okay,
not. So
that
he's
makes
not a
sense.
4 or 5. So then does he have to pretty much have to be then? Yes,
Three,
can he? Yes, because he can't help in that transfer at all, can he?
right.
So then that makes him a 3.
Okay. Well, now
Just
I get it. That makes sense.
just now it still doesn't totally make sense to me because I think of a transfer as a transfer. You're going from one place to another. But according to CMS, because someone else can use a Hoyer lift to transfer him, and they can put him in a chair, and he physically can stay in that chair and not slide out of the chair, then that makes
Yeah.
him not bedfast.
Well, yeah, I mean, it just says unable to transfer self and
Right,
unable to bear weight. So that's true.
right. But see, I'm throwing a ringer in here. Yeah, but this question is asking about his ability to transfer. It's transferring.
Yeah.
And I'm pointing that out because I had someone come to my last week and they're really trying to understand these questions. And he was just struggling with just trying to make sense from point A to point B.
I
And I
know.
let
I
him
do too. These are
and
kind of
I
tricky.
and I let him struggle from point A to point B. And that's why I'm letting you struggle a little bit. Because that's how in the end you'll remember this because it's like, and you get to point A and point B, and then I said, and you're completely right with your reasoning, and it does not make sense. And all I can tell you is they made the test, so they're allowed to do this. And in my mind, this doesn't make sense because it's transferring. If he can't transfer himself, he should be unable to train. He should be a five. He can't transfer himself. But that's not what they use. They're using the fact that he can sit in a chair that is not
Right.
bed fast. Well, what does that have to do with transferring?
Right.
But I didn't make the test. They didn't ask me. Had they asked me, I would have said, this doesn't have anything to do with transferring. But see,
Yeah.
having these discussions and making you work through that will hopefully help this to stick a little bit. So
Hmm.
when you have to answer this in the field, you're going to have a quad and you're going to say, ah, I remember this. It doesn't make sense, but because he can sit in a chair, he needs a Hoyer lift to transfer. But once I get him in that chair, so he's not a five, he's a three.
Okay.
That's all I got for you. I mean, to me, it doesn't make sense. It really does.
Yeah.
It's transferring,
Yeah.
but he is indeed a three.
Okay.
Okay.
I do understand it now.
Yeah. So what about Jesse?
Oh, Jesse, let's see.
Jesse, Jesse, Jesse.
Need supervision. Assist or transfers. They should need assist advice. He is a two.
And indeed, he is a two. Good. Let's go on to ambulation. So ambulation locomotion is another one people continue to have a hard time with. We've now improved the Gainesville office to 47%. Jack started at 44%, and I think they are still pretty close to 44%. They're somewhere maybe in the 30s. Still, neither office has met the criteria on this. And ambulation is looking at the ability to go from point A to point B. So you're looking at the ability to go somewhere. Um, Current ability to walk safely once in a standing position or use a wheelchair once in a seated position on a variety of surfaces. So that's one of the questions I often get. Yeah, but the person, they can go around inside their house wherever they want to go. Yes, but eventually the person has to leave their home, I would assume, because they have to go to the doctor's office. They don't live just inside their home. And the question is intended to go from point A to point B on a variety of surfaces. So keep that in mind when you're looking at this question. I think once again, this is a little bit complicated. So I tried to help you with the clarity of some of these questions. Um, Let me help you a little bit with what I did for this. Okay. So I gave you some guidance. I only did the first three because the other ones are pretty straightforward. So zero is no assistive device and no human assistance. Stephanie, that's how you and I are walking around right now. We're just strolling down the street. We're not swinging a cane next to us. We have no human assistance and no human assistance. Okay. One is a one-handed device and no human assistance. See, they can use a lot less words and say the same thing. Um, Again, you're looking at a variety of surfaces. So you're looking at even and uneven surfaces. You're looking at negotiating stairs with or without railings. Again, you're looking at a variety of surfaces, one-handed device, and no human assistance. Okay?
Okay.
Two is a two-handed device and and or intermittent human assistance. So if you need intermittent human assistance, even if you don't use a walker, you're a two. Again, you score based on the level of supervision and what you need to be safe, not on the device that you use.
Okay.
Okay. If you need to have a two-handed device, um, and need assistance, um, then you're a two. And then three, the big difference with three is you need that continuous human assistance, regardless of the device. It doesn't matter. So if you're using a walker, but you need continuous human assistance, you are a three. You see the difference?
Yes.
The big thing for two is an intermittent assistance, and three is continuous assistance. And then four, five, and six are the chair fast and the bed fast, which we already established on the previous question.
Okay.
Okay. Anytime you have a three continuous human assistance or supervision, it's going to be a four on the GG items, and just kind of make a mental note or make a written note of that when we get to the GG items. A three here, continuous assistance, is a four over on the GG items. And we're getting
Okay.
to those in just a minute. Okay, so these are much clearer than what this is up here. I don't know why they have to make them so difficult. Again, you're looking at a variety of surfaces. So if you have somebody who's really safe in their home, that's not the intent of this question. The intent of the question is, well, what happens when they go outside on a variety of surfaces? That's what you're looking at. Okay,
Okay.
so read the considerations. Read the considerations, and then we'll do the practice questions. And I talk about the GG questions, and I don't give you much information, but you have all that you need in order to be able to answer the question.
So its the answer is three.
Most likely three. When could it be a two? Or could it be a two?
Oh, okay. Um,
See, I told you when it's four, it's usually going to be a three.
so the best possible answer.
Yeah.
Okay.
It's going to be a three. You're right. Because usually if it's, I told you if it's a four on the GG, it's going to be a three here. Unless it was really, really intermittent, but usually a four on the GG is going to be a three with continuous here. Yeah, and that's just a pretty good rule of thumb.
Okay.
Okay, so we're almost done with this part. Okay, so this is another question that's real important. And this one we continue both offices. We haven't changed a whole lot. In fact, the Jack's office is making more mistakes, and the Gainesville office has only come down to about 35%. So we're still having trouble with it. So let me go over this. This is the M1033. This is the risk for hospitalization. And remember, all of these areas need to also then go into the care plan if you're having trouble with these. But let me go through some of these, okay? So history of falls, two or more falls. And what you're going to do is you're just going to select whichever of these apply. History of falls, two or more falls, or any fall with injury in the past 12 months. So I made mine, and I don't know why the yellow didn't stay or any fall with injury in the past 12 months. This includes witnessed and unwitnessed falls. You want to check the referral sources, ask the family, ask the patient. You can usually find the history of two or more falls, um, but any fall with injury that's happened in the last 12 months, and you're going to check them on this one. And this, again, just speaking for the increasing the risk for hospitalization. Unintentional weight loss of 10 pounds or more in the last 12 months, you've got to ask them. Many of these are dismissed. You can't tell just by looking at the patient. And I'm going to give you an example. I had a patient who was an ALS patient, had been admitted by the physical therapist. And I went in, and because the patient was now having trouble with swallowing, and I was brought in at the very beginning at this, right along the same time as in the first 5 days with the start of care. And none of these, that had not been checked on the patient. And so I am asking her as part of her swallowing assessment, well, you're having trouble swallowing. Are you losing any weight? And she said, yes. She goes, I'm losing 10 pounds a month. She said, I have lost 100 pounds in the last 10 months. This had not been marked because she had been chronically obese, and yet she was still a little chubby. So the therapist who did her start of care didn't think to ask her because they thought surely she hasn't been losing that much weight. And she had lost 100 pounds in less than a year because she had been so overweight. So it's really, really important to ask the question. And you're just looking at 10 pounds. She was losing 10 pounds every month. And you're just looking at 10 pounds or more in the last 12 months. And she was losing 10 pounds a month.
Wow.
Multiple, yeah, 10 pounds a month she was losing. Multiple hospitalizations. This is 2 or more in the last 6 months. And these are acute care hospitalizations only. Multiple ED visits. This is 2 or more in the last 6 months. And these are only hospital EDs, not urgent cares. These are declines in mental, emotional, or behavioral status in the last 3 months. Remember, for home care, behavior equals function. How many of our home care patients have had a change in their function? Probably the majority of them. These can be temporary or permanent changes, and treatment is not necessary. During COVID, this was about everybody that we saw, whether they had COVID or not, because everybody was so impacted. They were anxious, they were nervous. So that's all you're looking at. Ah, boy, this thing is very jumpy today. Number 6, reported or observed difficulty complying with medical instructions, medications, diet, exercise in the last 3 months. And I'm going to ask you all, how well do you follow exercise recommendations? Ask my nurses, how well do you take your medications as recommended? How well do you follow diets as recommended? Most of us do not. Currently taking 5 or more medications. So this is what CMS says. If the person has more than 5 or more medications on their list, and this includes all medications, this includes over-the-counter meds, herbals, prescriptions, vitamins, oxygen. If they have 5 or more medications on their list, and they say to you, yeah, but I'm only taking 3 of them, it doesn't matter. If they have 5 or more on their list, then you're going to count this as yes. And if they have over the counter, if they have Tylenol and ibuprofen and vitamin C, there's 3 right there. Okay, this is over the counter, herbal, prescription, vitamins, anything at all, they all count. So this is going to be just about everybody. Currently reporting exhaustion, and this is mental and physical, and any other risks. And I never knew what these other risks were. So these other risks are things like the social determinants of health, not having transportation, having problems with health literacy, having diabetes, having an unsafe neighborhood, not having transportation, having slower movements, having trouble getting up to walk, having a poor support system, feeling lonely. Okay, anything at all is going to be fall into the category of number 9. Okay, any questions on any of that?
I don't think so.
All righty. So I'm going to stop this one. I'm going to speed us up a little bit. Go back to here. So we've gone through all of these. We've gone through all of our M1800s. And now we're on to the GG questions. So notice with these GG questions, now we're going back to where we were. So this is back in the PDF where we were. This is page 12 of the same section, but now we're in the beginning of it.
Okay.
Okay. The coding has been reversed. So now the higher the number, the more independent they are. And I think these are very easy. Independent is just what you would think. It's independent. Oh, this isn't page 12. Hang on. I'm on the wrong page here. Page 15. Sorry about that.
Oh,
Wait. Yeah, page 15. Gosh, that's so weird. Yep, page 15.
um,
Did you find it? Is it page 15?
not for me there.
For me, it should be page, let me see. Yeah, page 15.
Okay.
Yeah, page 15 of 35 in your Oasis section.
Okay. Page 15. All right, let me
15
go
of
back.
Page 15 of 35. You go
Okay,
back.
I have it.
Got it?
Mm-hmm.
I had not turned my page in my notebook. Page 15 of 35. So the numbers are reversed. So now the higher the number, the more independent they are.
Okay.
And independent is what you would think. They can do them all by themselves. Needed some help. Is just needing a little bit of help. Dependent, they're completely independent. You really don't want to do unknown or not applicable for these, because this is their prior functioning, so you want to ask. You don't want to not answer these questions because we're going to start getting dinged for this. So
Okay.
just ask. Yeah,
Okay.
just ask. Don't leave it blank. And this is the prior device use. Notice it's not exhaustive. There's no cane on here. So that means that CMS isn't interested in the cane. So again, if the equipment is not listed, you're going to just put in there just whatever CMS puts in there.
Okay.
Okay? And if they didn't use any of it, then none of the above.
Okay.
Simple as that. Okay? So these questions are a little bit different from the other ones. Again, we already talked about scoring it before you fix it. And for the GG questions, this is the scoring. So you have a 6-point scoring that you're going to use. And the use of the assistive device does not impact the scoring on these. Um, these items moving forward from here, going forward, several of these items that are highlighted, that I'm going to have highlighted that I'll show you, are going to comprise the discharge function score, and I have them highlighted down here for you. And these you'll see we're going to fit in with some of those M1800 questions that we just did. They're not exactly the same question, but they can't conflict with what we just did. So for example, we just talked about if the person needed assistance for a number 3 over on the M1800,
Mhm.
here's your supervision right here with a 4 here. Here's your independent, a 6 here. Your setup or cleanup is a 5. Here's your supervision. Then you've got a partial or moderate versus a substantial or maximum assistance. Here's your dependent. Now, here's what I'm going to tell you about these. These are the not attempted codes. We've been able to use them, but starting in January, CMS has come up with a very elaborate code that if we now use these non-attempted code, like 9 is they could do it before the current illness, but now they can't. They're going to go in and put in their own number, and pretty much we're going to be dinged for it. So, to the very best of your ability, if you can use your clinical judgment and assign them something up here that would fit, usually it's going to be either a 1 or a 2, then assign them either a 1 or a 2 unless they absolutely like flat refuse it. But they
Okay.
do allow you to use your clinical judgment. Don't skip them. And if you're able to use your clinical judgment, um, like you can see me walking around. So even if it's pouring outside, you can see me walking in a room. And so you could make assessments based on how much I'd be able to walk and be able to do things based on what you can see me walking around your house. And so those are the kind of clinical judgments that you want to make.
Okay.
Okay. The person has a few steps, or if you can, if there's a little step down, or you can even ask them now, we'll even let you ask the family. So those are some of the things. But remember, this is not an interview assessment. This is a show me assessment. Okay. So you
Okay.
have you have eating, oral hygiene, and there's your toileting hygiene that goes right along with the M1800s. You have all the other ones that have to go along with them, but these are the ones that are counting most for that discharge function score. And here's all of your cueing. Oops, I knew it was going to do that. Your cueing and your coaxing that are going to help you with those scorings. I've tried to give you some cues along with those.
Okay.
Okay. Where's the other ones that I put in here? Let me see. Hmm, I don't have walking. Let me see the walking. I did the ambulation. I tried to give you some help with the ambulation ones too. Let's see if I can find where they are. And see, these are all of the different follow. These are all the self-care. These are all the different points of care. So I'm not going to go through them at all the different points with you
Okay.
because that would take forever. And there's no point. See, that's why I say they're not asked, you're not asked all the same questions at all the same time points. These are all still the self-care. And then we have some mobility questions. Okay, oh, here's the mobility question. So when walking, the patient is able to take a standing break and still be considered completing the task, but they are not able to sit. So if they have to sit, the task is not completed, but they're allowed to just pause a minute.
Okay.
Okay, and here you're looking at your sitting on the side of the bed. There's your sit to stand, your chair to bed to chair transfers. There's your toilet transfers. See, here's your walking 10 feet, you're walking 50 feet. See, before we just had ambulation.
Mhm.
Now we've got walking 10 feet, more specifically, and walking 50 feet with two turns. So
Okay.
again, you want to try and say, well, if the person can walk 50 feet, you can assume they can walk 10 feet. If they can walk 10 feet really well, you can probably assume they can walk 50 feet.
Mm-hmm.
You can probably assume they walk 150 feet, although these are the only ones that are involved in that discharge score. But you see how you want to look once and score as many times as you can. Use your clinical judgment.
Okay.
Don't leave them blank. Okay. And these are all of the questions that go along with it.
Okay.
Okay. Don't want to leave them blank.
All right.
These are all of the mobility questions. Okay. Let's go up here and take a look at a couple of these. For the urinary tract, the bowel and bladder. Has the person, I want you to pay attention to the timelines. Has the person been treated for urinary tract infection in the last 14 days? Please notice the timeline. It's in the last 14 days. And
Okay.
we're almost done with this, so hang in there.
Okay.
A urinary catheter. Want to pay attention to if they have a catheter and if they're incontinent or dependent on a time voiding program. That would also count as being incontinent. Bowel incontinence frequency, consider the day of assessment or the relevant past. Remember for the coding, Symmetry does our coding for our ICD-10 codes. Ah, but they don't give you any information on, you have to go in, you'll have the codes here, but you have to go in and put the coding for the numbers here. And they don't give you in crescendo any idea on how to code those numbers. So here's the numbers that you're going to use. So 0 is if they're asymptomatic and no treatment is needed. And probably none of them are going to be 0 because otherwise they're not going to be listed on there.
Mm-hmm.
1 is if they're well controlled with therapy. Most of the numbers that you're going to have on there are going to be either a 2, a 3, or a 4. If they have frequent rehospitalizations for it, it's going to be a 4. If they need frequent adjustments or in the treatment or dose, it's going to be a 3. If it affects their daily functioning or needs ongoing monitor, like if they have to go to the doctor fairly often, that's going to be a 2. If they need ongoing, even just if they need regular monitoring, annual blood work, that's going to be a 2.
Okay.
So just so you see what numbers to put in over here.
Okay.
I don't know how they can expect you to do that without giving you the numbers, but
Yeah.
they do. Here's the one we just did. Here's the M1033. We already kind of took a peek at these pain questions. Here's the 3 pain questions. So I would start with these 3 pain questions. So, Mr. Brown, over the last 5 days, how much of the time has pain made it hard for you to sleep at night? How much has it limited your participation in rehab or therapy? How much has it limited your day-to-day activities? And if he says, well, frequently it has. And then you go back to the pain section, the pain question, and say, so, Mr. Brown, you said that pain frequently interferes with your day-to-day activities. On a scale of 0 to 10, what number would you say that is? And then you go in and assign it a number.
Okay.
Okay? And pay attention that there is a difference between a 0 and a 1. They're not the
Okay.
same. They're not the same.
Okay.
Okay. Let's talk about the falls. So falls, we talked a little bit about this, if I can get it to go and stay where I need it to be. Ah, which of course I can't. Okay, so falls, remember they have to be recorded in your adverse events.
Mm-hmm.
So has the patient had any falls? You're going to say either yes or no. And each incident is counted just as one fall according to the highest level of injury that occurs.
Okay.
So somebody falls, they break a bone, and they have a bruise. It's one fall, okay?
Okay.
And then no injury, injury, or major injury. So they had one fall and they might have had a major injury. They might have had several injuries, but you're going to code it according to the highest level of injury. Okay.
Okay.
Think we already talked about dyspnea when we did the documentation for the start of care. You're going to consider the day of assessment or the prior 24 hours. Remember, you're going to start here. So, Mr. Brown, are you having any shortness of breath like when you're talking or you're eating or when you're getting dressed? I like it because it gives examples.
Mm-hmm.
And then whatever he says here, then you go back to the cardiopulmonary page
Mm-hmm.
and you match whatever the drop down is there
Mm-hmm.
to whichever one of these Oasis things. Only pick one on the cardiopulmonary page that matches what he says here.
Okay.
Okay. Remember for the swallowing and nutritional, remember the height and the weight at the start of care have to be measured.
Mm-hmm.
And if the numbers are outside of the parameters, you can put in dashes. And I've given you what those parameters are. So if the height is less than 50 inches or more than 80 inches, or if the weight is less than 65 pounds or more than 440 pounds, then you would put dashes here. And I don't know where else you would find those. So just keep your book with you so you remember that you have this information in there.
Okay.
Okay. Oh, let me tell you a little bit about shortness of breath before we go on. If the patient uses oxygen continuously, you're going to use you're going to measure their dyspnea on oxygen. If they use it intermittently, you're going to measure their dyspnea without oxygen.
Okay.
And continuous use is greater than or equal to 14 hours a day. You're going to code it based on the patient's actual use of oxygen and not the patient's order. That was particularly important during COVID. And of course, COVID is not gone away. We are have patients on that have COVID again. A lot of the patients were supposed to be using it all the time, and the patients were just using it intermittently. So you're going to code it based on what the patient is doing.
Okay.
Be sure again that this M1400 is consistent with the cardiopulmonary. And at the end, we're going to do the 110, the medical ventilation. I'll show you when we get there. There's three different sections that it all has to be consistent. They don't make it easy for us. That is the redundant part. You have to enter it in three different sections.
Well, at least you know you'll be matching.
Well, hopefully you will. Yeah, hopefully you will. Okay. And I don't know why this didn't stay, but it should stay on here. The IV feeding, that's for like a TPN, port for hydration, report of previous dehydration would be for the IV feeding. The feeding tube is only to deliver nutrition or hydration. And the therapeutic diets can also include things like food allergies, no peanuts, and protein supplements for malnourishment would also be included with that.
Okay.
I don't know why that went away, but it did. Oh, there it is there. That's weird. Skin conditions, be sure that you never downstage. You have to assess them weekly. You assess them each visit. You measure them weekly, and you take pictures at the start of care, the rock, the research, and whenever it's appropriate. The status goes in the reevaluation section. The skilled care goes in the care plan under the specific skill addressed. And for your notes, wound care done is not sufficient. Be sure that you always include the patient's response to the skilled care. And again, remember that just if it was a stage 3 or a stage 4, CMS considers them always a stage 3 or a stage 4. They just become a healed stage 3 or a stage 4, even though they
Okay.
may present as something different. Oh, and they said, refer to the handout. And I give you this handout in the back of that other handout we were doing all those sample questions.
Mhm.
Refer to the handout from CMS surgical wounds, as their definition does not always align with the NPIAP. Generally, a surgical wound is counted for 30 days until it reepithelializes. Then it becomes a scar, unless it dehisces and becomes infected. An incision is a surgical wound. The staples and the sutures are not. A pressure ulcer closed with a flapper graft now becomes a surgical wound and not a pressure ulcer. Most ostomies are excluded from surgical wounds unless it's a takedown. And I've given you every single list, every single thing that I could find. It's in the back of that handout.
Okay.
I had one of our nurses ask me to create a list for them, so I did. And so here's where you go in and score them. And most nurses don't have a hard time with this unless they downstage them. Just don't ever downstage them because they never downstage. And this is when you do your medications, um, when you do your med reconciliation. So you have to, this is a new question that CMS added in. You want to put in here the class of drugs that they're taking, but the indication for what they're being used for. CMS is using this to track to see if the patients are being given written information on why they're taking a certain medication. And if you can't find it in their discharge instructions or on their bottles, they do not want you digging for the information at the very beginning. Now, obviously, when you do your medication teaching, yes, you're going to have to find that out. So, so you can do the teaching, but for the purposes of the start of care and the ROC, CMS does not want you to note that. They just want to know, do the patients, are they being given that information when they get out of the hospital on why they're taking certain medications? So
Okay.
don't spend tons of time digging for that. Now, do you need to know why they're taking a medication? Yes. But for the purposes of this, no, you don't have to look at all that. But you are going to need to find it out, of course, to do your instruction. Okay?
Okay.
So when you're doing your medication review, you need to consider all of the medications, and you have to really watch for the consistency of your documentation. If no issues are found, if issues are found, then you're going to put yes. And then you have until midnight of the next calendar day to complete whatever it is the doctor tells you to do. If you contact the physician by midnight of the next calendar day, but they haven't called you back so that you couldn't do the action, you still have to answer no. And CMS realizes that we might get dinged for something that wasn't our fault, but that's still how we have to answer the question.
Okay.
Then at discharge, you're going to get this question. Did the agency contact um, and complete the physician recommended actions by midnight of the next calendar day since the start of care or rock? This question is going to match whatever you did up here. So if you didn't have any issues here, this is going to be NA. If it's no here, it's going to be no here. If it's yes here, it's going to be yes here. Okay,
Okay.
so whatever you found, if there were no problems here, then there's going to be no problems here. Because
Okay.
the time periods, it restarts the time, and it doesn't tell you that, but the time period restarts. I have that written somewhere a little bit more clear than what I'm just saying. Um, I'm not saying that very clearly, but
I
that's
understand.
yeah, that's the time period.
Mhm.
It includes the entire episode of care, including the start of care. There we go. That's a better way to
Okay.
put it. Yeah, they don't tell you that. Okay, management of oral medications. This is another one that we have a really hard time with. Um, because if somebody hasn't done their medications for years and they have a cognitive impairment, again, I don't know how we're going to make an improvement on this. Sometimes we can help with getting them the medications that are in the little things that you just pop the medications out. Sometimes they can set reminders. Sometimes we can ask the family to check them instead of just doing it all for them.
Hmm.
I mean, I think we always are going to err on the side of cautions when it comes to medications, but we tend to overestimate how well people can do with some of these medications. A zero
Yeah.
means the person is able to correctly take their medications, every single medication, every single time, is what that one means. Um, and then the rest are pretty self-explanatory. One, they can take them if somebody sets up a diary for them,
Hmm.
or helps them. This means they have to be able to both um, assist with water. This means that they can get everything that they, and see that, I don't think that showed up either, did it? Oh, here it does. If they need assistance with water, it's a 3. If they need assistance with access, it's a 3. If they're cognitively intact, but choose not to take a certain medication, it might be a 0.
Hmm.
Willingness and adherence aren't factors. So basically, they have to be able to do all of this themselves. If they need assistance getting the water poured for them, but they can do everything themselves, that's still considered a 3. If they
Okay.
need someone to pour the water for them or to take the medication out of the bottles for them, that's considered a 3. So we have to consider all of that.
Okay.
Okay. And the injectables, they have to be able to both access, draw, inject, and correctly dispose of in order to be able to be considered independent.
Okay.
Okay. We have just a few questions left. This question was just added in the last time, and we about flipped out when they added it in because this is the first time that home care was responsible for knowing about the programs that the patient was involved with outside of home care. So I've tried to help you with a few of them. Here's where, if they have a BiPAP or a CPAP, this is where that's involved, even if the patient doesn't use them. Here's the mechanical ventilation that we have to be, that's real consistent with that shortness of breath. If they have a trach, if they have any kinds of suctioning, if they have oxygen, if they're on chemo, IV antibiotics. So just kind of take a look if they're on dialysis. The reason that CMS put that in there, again, it's those social determinants of health. They want us looking at the whole person. Does the person have adequate transportation? Can they pay for the services they need? Do they have adequate support system? So that's where they want us really looking at the whole person and the whole care.
Okay.
I don't know why it just flipped up instead of down, but it did. Let's see if I can get it to go down. Oops. Here's the new question. Here's the COVID vaccine. And it's just asking you if the patient is up to date. And what does up to date mean? If the patient has had a booster after September of 2024, they are considered up to date. If they refuse to answer or have not received one or more doses or you can't determine their status, coded as no. So I don't know anybody who's up to date. Gosh, I mean, I thought I was real up to date, but
I know.
having a dose since September of 2024,
I know.
you know,
I
but
didn't get any of those.
yeah, no, me either. So, I mean, I went to Paris in 2023 and I got one right before I went to Paris in 2023. I thought that was doing really well.
Yeah, that's doing pretty good.
But yeah, I had every booster up until that point, but yeah, oh well. So, uh and we are still in the collection period here. So, does this episode of Care include any dates on or between October 1st and March 31st? This is going to be yes. And that includes even one visit between this time period is going to be yes. And we are still in this time period. And we are supposed to, at the very least, offer it to them. And offer it just means that we are going to help them to make arrangements to get it somewhere.
Okay.
And then let me go through this with you. So these are kind of tricky. NA is, if any of these things don't apply to the person, you're going to select NA.
Okay.
If any of these things apply to the person, so like falls, we talk to just about every person about falls,
Mm-hmm.
pain, we talk to just about everybody, then these should be ones
Okay.
because a zero means that it applied to them, but we missed it.
Okay.
So you really don't want to answer a zero to anybody.
Mm-hmm.
It should be either an NA or a one.
Okay.
And that is the end.
Okay.
So I'm going to stop sharing from here. And if you were watching this video, um, I'm going to be communicating with you, or I'm actually not going to be doing staff development a whole lot longer because I'm also now the new rehab director for the Gainesville office. So whoever will be following me will be contacting you or possibly doing this live with you and am answering any questions that you might have. So I'm going to stop the tape now so I can do that with Stephanie. Goodbye. Thank you for your attention.